So now I will invite Professor Dharmen Jain for his talk, Hypertension Guideline Update 2021. And for chairing the next session, I invite Dr. R.K. Srivastava and Dr. A.K. Sharma, sir. Sir, please come on the desk. Over to Professor Dharmen Jain. Dr. Ankit, after Professor Dharmen Jain, your talk will be held.
Thanks, Dr. Alok, for giving me opportunity in HIC, and I congratulate for wonderful sessions in HIC every year. Ankit, can you stop sharing?
I have stopped.
जैन बॉस करिए, अंकित का स्टॉप हो गया. Was we are running short of time, so please try to complete within 20 minutes. जैन सर स्क्रीन शेयर करिए.
Okay.
हाँ, दिख रहा है.
Okay. So the topic given to me is recent hypertension guidelines. So I would like to discuss in these points BP classification and targets, clinical evaluation and CV risk assessment, then management of hypertension, BP threshold, impact of different guidelines, and then non-pharmacological and then pharmacological intervention, then according to comorbidity, then monitoring and adherence, and then summary. So there are different guidelines available, 2017 ECCHA, 2018 ESC guideline, and 2021 ESH guidelines. So for BP classification and targets, hypertension BP level initially in 50s and 60s, it was more than 180 by 100, and then they in 70s 84 it was 162 by 95, and then 85 to present it is more than 140/90, we call it hypertension. So there are different guidelines for BP classification, and in latest ISH 2020 they made it the high normal stage 1 and stage 2, and Indian guideline 2019 still have the stage 3 hypertension, that is more than 180 or more than 120. There is another group is isolated systolic hypertension, where the systolic BP is high and the diastolic is less than 90. So it has two grades, 140 to 159, and then more than 160. So this is a separate group of isolated systolic hypertension. So the BP values for diagnosis of hypertension by different methods. So the office BP is more than 140/90, we call it hypertension, and if it is home BP, then mean of 135 and 85 is hypertension, and ambulatory BP daytime mean is 135/85, and night 120/70, and 24-hour mean is 130/80. So these numbers we have to remember when we are evaluating the patients. And target BP is another issue, that how much target we should have when we start the treatment. So the JNC8 has two groups according to age, more than 60 year and less than 60 year. More than 60 year, they have little higher side 150/90 target, and less than 60 year, less than 140/90. And similarly, the latest international guidelines also have the age group less than 65 year 130 less than 130/80, and more than 65-year, less than 140/90. So Indian guidelines and other guidelines have less than 140/90. And recommended target BP by most of the guideline is less than 140/90. However, age and drug tolerability are the important variable and to define the target. So we have to individualize according to age and drug tolerability. So target BP, target BP reduction by at least 20/10 mmHg and ideally less than 140/90. That is aim for BP control within 3 months. And if we go for optimal, then it is should be less than 130 if tolerated, but it should be more than 120/70. And more than 65-year, it should be less than 140/90 if tolerated, but consider an individualized BP target in context of frailty, independence, and likely tolerability of the treatment. So we have to individualize in older elderly patients, and the targets should be aim for the BP control should be within 3 months. So ideal target is less than 140/90. Managing hypertension in 2018, which guideline to follow? This article says that 130/80 mmHg as a diagnostic threshold and contribute to more sustained target organ protection and CV disease prevention. Optimal balance between the magnitude of achieved BP reduction and the tolerability of treatment in single patient is the key. So we have to see the reduction in BP and tolerability of the treatment. Both should be balanced and then according to individualize in the patient. In Asian population, achievement of normal or optimal BP level for prevention of stroke remains a priority in the treatment of hypertension. The lowest well-tolerated BP is the better. The tolerability we should see the in each and in individualized patients. So ESC 18 guidelines said that BP measurement plan should be if the patient has a optimal BP, then we can repeat it every 5 years. If it is normal BP, then every 3 years, and if it is high normal, at least annually we should check it, or we should confirm it by out of office BP measurement by ABPM or HBPM, home BP or ambulatory BP. Then if it is hypertensive, then repeated visits for office BP measurement, and out of office BP measurement also better for monitoring. We can do ambulatory BP monitoring or IH home BP monitoring, and indications are there for these monitorings that are beneficial in follow-ups. So in another ISS 2020 guidelines, international guidelines for hypertension, and these are having a, if it is less than 130/85, then we should remeasure every 3 years and 1 year in those with other risk factors. And if it is 130, 159 or 85 to 99, then if possible, confirm with out of office BP so that we can rule out the white coat hypertension and masked hypertension. Alternately, we can confirm with the repeated office visits. So out of office BP can be by ABPM or HBPM to rule out the white coat or masked hypertension, and confirm if it is more than 160/100, we should confirm it within a few days or weeks. BP measurement plan for 2021. So it should be, we should remeasure at every year if it is normal BP, and 6 months if other risk factors. High normal BP, then we should consider for masked hypertension, and if it is hypertension grade 1, we should consider for white coat hypertension. These things should be ruled out first before labeling the BP. And if it is grade 2 to 3, then sustained hypertension is highly probable, and we should confirm within few days, and ideally use home or ambulatory BP for confirmation. And white coat and masked hypertension, we all know that white coat hypertension may be there if the patient is having high BP in the office and low BP at home. And similarly, opposite of that is masked hypertension, and that is high BP in the home, but it is low BP in the office. So these things should be ruled out, and we should document the sustained hypertension before labeling the hypertension. These are there in the 15 to 25% white coat and 10 to 20% masked hypertension are there in our OP. So we can diagnose these things by ambulatory or home BP monitoring, and management for white coat hypertension is only lifestyle change and annual follow-ups. We can consider drug therapy if the patient is having a very high CVD risk. And masked hypertension, we can do only a lifestyle change and think of considering drug treatment if we can document it as sustained hypertension. clinical utility of office and out of office BP measurement methods. So for screening purpose, office BP or public space BP monitoring is good enough. For initial diagnosis, 24-hour ambulatory BP monitoring or home BP monitoring is good. For treatment titration, also office BP or home BP or 24-hour ambulatory BP is good. And for follow-ups, we can do the home BP monitoring. We should encourage patients should come with the home BP readings and in your office for follow-ups. And so main indication of office BP is only for screening of untreated individuals or follow-up of the treated patients. And for home BP, it is useful in long-term follow-up of treated patients. It's a preferred method. And initial diagnosis, 24-hour ambulatory BP is helpful. And screening of untreated individuals, we can go for the pharmacy BP or opportunistic screening can be done at public places. So that is for a screening purpose. So these are the utility of office and out of office BP. So out of office BP method is helpful in diagnosis, but follow blood pressure measurement protocol to get accurate reading in public spaces may not be
Recording
feasible.
stopped.
Clinical evaluation and CV risk. So clinical evaluation, we can do medical history by recording any current and past BP value, record the current and past antihypertensive medications, family history of hypertension, CVD, or stroke or renal disease, lifestyle evaluation, exercise levels, body weight changes, dietary history, smoking history, alcohol use, recreational drug use, sleep history, impact of treatment on sexual function, history of any concomitant CV risk factor. So this history is very important in each and every patient of hypertension. And routine tests are CBC, RFT, LFT, RVS, uric acid, and 12-lead ECG. And the BP guidelines on CV risk assessment, the 2017 ACCHA guideline has given ASCVD risk calculator, and more than 10% 10-year risk is more aggressive.
Recording in progress.
And if it is in ESC, ESH 2018, they have given a computed score system for risk modifiers like hypertensive induced organ dysfunction, or with more than 10% 10-year CV risk, more aggressive treatment is required. So these risk calculators are available, and we can calculate easily by our mobile device or computer device in each and every case. And the score system estimates the 10-year risk of first fatal atherosclerotic event. So CV risk assessment by the score system is recommended for hypertensive patients who are not already at high risk or very high risk due to established CVD, renal disease, diabetes, or mildly elevated single risk factor or hypertensive LBS. So if these risk factors are not there, then it is not very high risk patient, and we should calculate the 10-year risk for first fatal atherosclerotic event by this score calculator. A previous limitation of a score system was that it applied only to patients with 40 to 65 years, recently adopted for patients for age of 65 years. So we can see that when risk factors are there, then the risk increases accordingly, and we can grade the patient's risk and accordingly try for treatment. Hypertension mediated organ damage, this HMOD assessment by ISH 2020 is recommended. So essential is serum creatinine, EGFR, depistic urine test, and 12-lead ECG. And optimal tests are brain, eye, heart, kidney, and arteries, and organ damage should be optimum for the assessment. And serial assessment of these hypertension mediated organ damage may help to determine the efficacy of treatment. So BP thresholds for initiation of pharmacological treatment is, we already have given in the previous table that lifestyle advice is given for all. And if the grade 1 hypertension is there, then if the patient is having high risk, then we can start immediate drug therapy. And if the drugs are available, then we can start the medication. And if it is not there, then drug treatment in low to moderate risk patients which are not having CBD, CKD, diabetes, or HMOD, then we can think of lifestyle changes for 3 to 6 months, and then we can think of starting the drug therapy if it is not controlled. If it is grade 2, then immediate drug. If grade 2 hypertension, then immediate drug therapy with the And in the ESC 2018, they have given the lifestyle advice for all. And in high normal BP, consider drug therapy in very high risk patients. And grade 1, 2, 3, the immediate drug therapy is recommended. And for the patients which are having stage 1 hypertension and non-pharmacological therapy, if they are not in the high risk group, then the initial non-pharmacological therapy, and then 3 to 6 months we have to reassess and what to do next. It is not given in these guidelines. So there are AHA scientific statement came recently in 2021 for those patients which are having stage 1 hypertension with low 10-year risk. So this guidance gap was there. So stage 1 hypertension, 10-year ASC with risk less than 10%. This is a specific group where risk is less and stage 1 hypertension is there. So initially you started with the lifestyle therapy. If not achieving goal BP less than 130/80 within 6 months of lifestyle therapy, then we can think of addition of medication from 4 classes of recommended drugs. In young, especially with a family history of premature CVD, antihypertensive medication can be started. And evidence for these consideration is based primarily on observational data. Clinician may use their clinical judgment in considering the option of medication for these patients. So these patients which are stage 1 and less than 10% risk, these are low risk patients. Still they can be started with the pharmacological therapy after 6 months of non-pharmacological treatment if BP is not at the target of less than 130. So this is latest statement from 2021 from AHA to fill the gap in the guideline. BP threshold for the treatment in different comorbidities. So we have already discussed in different guidelines that ESC 2018 guideline retained the definition of hypertension more than 140/90 and encourage the patient discussion and education to get the less than 130/80 and limits on BP reduction not below 120/70. It is not given by any other guideline that it should not go below 120/70. So we should be cautious when the BP goes below that. We have to reduce that medications. So Indian guidelines for BP threshold and target in different comorbidities. So if the age is less than 65 years, then if it is high ASCVD risk, it is 140/90 and target BP is 120/130/70/80 and if it is low ASCVD risk, the target is 140/90 threshold and target is 130 to 140/70/80 and if age 65 to 80 it is same. Age more than 80 years, then it is little higher BP threshold to start the treatment 140 to 150/90 and the target is same. With other risk factors, diabetes, history of stroke, CKD, the threshold and target same as age 65/80 or ASCVD risk. And then especially in CAD and heart failure, they have given threshold is 130/80 and to start early, and target is also less 120 to 130 and 1/70/80. So CAD patients, heart failure patients, and high ASCVD risk patients, these patients have a target BP 120 to 130/70/80. So different guidelines impact. We apply the guidelines. The population which is having hypertension in India will be on higher side. If we consider only first reading, then by ESC or any other guideline, the number is very high in comparison to if we follow the guidelines criteria. So if we, for example, if we apply for ESC guideline in Indian population, if we give only first reading, then it is 148. If we take reading as per guidelines, it is 113 million population at target for hypertension. So similarly, other guidelines also show clearly that we should take a proper guideline directed reading in each and every patient. And impact of intensive BP control also. The evolution of BP threshold for initiation and titration of antihypertensive medication. So for the graph shows that BP threshold at which antihypertensive medication should be initiated. So BP threshold was initially it was more than 160 as I have shown in the first slide, and it is more than 140 in the latest guidelines. So So there are various trials which have supported this finding, and there are trials which are having drug versus placebo, or like VA1 Australian trial, MRC, Shape, Stop, Cystio, Hybrid, and Hope. And then comparing different drugs like Alhart and Accomplice, and then comparing different BP targets like SGFP, HOT, and UPPDS 38, and Accord, and SPS3, and Sprints. So these are Sprint and Accord. These trials are comparing different BP targets, and then initially it was different targets for 60 year, less than 60 year, and more than 60 year. Now they have given the targets for less than 65 year and more than 65 year. So this is another interesting sprint trial finding, that involving the patient at increased risk for cardiovascular events. The intensive treatment to lower the BP was associated with lower rates of fatal and non-fatal events and death from any cause. So they compared the standard treatment with the intensive treatment, and so intensive treatment is found to be beneficial in the sprint trial. And the sprint and accord trial, these open the door for even better management of BP to the benefit of patients. So if we go for the the treatment by intensive therapy to control the optimum BP, then it is more beneficial. And non-pharmacological therapy. So this slide shows the benefits of physical activity, healthy diet, weight loss, reduced intake of dietary sodium, enhanced intake of dietary potassium, moderation in alcohol intake. So the in an alcoholic person. So these all have the benefit. If they are hypertensive, it reduces the BP to the tune of 4 to 11 mmHg, and if they are normotensive, still they have the benefit of 2 to 4 mmHg reduction in the BP. So these non-pharmacological interventions should be tried in each and every patient of hypertension initially. And the pharmacological intervention. So ISS 2020 says that in step 1 we can try A plus C, and in step 3 we can step 2 we can increase this dose of A plus C, A for ACE inhibitor or ARB, C for calcium channel blocker, and triple combination we can combine the A plus C plus D. Even diuretic can be added. And still in step 4, if it is resistant hypertension, we can add the spironolactone or other drugs like alpha or beta blockers. So like that we can add the drugs step by step, and when possible the use of single pill is emphasized. So single pill combination should be considered for the improvement of efficacy, efficiency, and tolerability. So the emphasis is there for the single pill, so that the efficacy, efficiency, and tolerability can be increased. So similarly, the 2018 guidelines also recommend the initial therapy as a dual combination. Every guideline is saying that we should start with the combination therapy. It is better to reduce the side effect. Lower doses of two drugs, so ACE inhibitor or ARB plus CCB or diuretic. Then in step 2, we can combine these three, A, C, B, A, C, and D. And in resistant hypertension, we can go for the spironolactone 25 to 50 mg or other diuretic or alpha blocker or beta blocker. Regarding beta blocker, they consider beta blocker at any treatment step when there is a specific initiation, like for their use of beta blocker, like heart failure, angina, post-MI, AF, or younger women with planning or pregnancy. So these patients should be given the benefit of beta blockers. So treatment initiation, we have already discussed the ASC guideline, monotherapy versus combination therapy, and they demonstrated this ABCD. They have demonstrated effective reduction in BP and CV events in different RCTs, and they are indicated as anti-hypertensive. And combination is recommended for most hypertensive patients as an initial therapy. It is class 1A recommendation. And preferred combination should comprise of RAS blocker with a CCB or diuretic. Beta blocker are combined with any other drug, as we already told, indications are there. Initiate an antihypertensive with two drug combination, preferably a single pill. So that is very important. Emphasize the single pill should be given. And combination of two RAS blocker is not recommended. It's class 3. So two RAS blockers should not be there on your prescriptions. People are prescribing ACE inhibitor or ARB, which we have seen in a few prescriptions coming from periphery. So the emphasis is there. It is a class 3 recommendation. Two RAS blockers should not be combined. Starting with the single pill combination, so the benefits are there. It is a strong recommendation as first choice for ESC and ISS guidelines. So in 2021, this is the emphasis on single pill is there, and meta-analysis including 42 trials showing the SPC is more efficient to reduce the BP than doubling the dose of the same drug. So combination therapy should be started. WHO added the WHO added the first time the single pill combination in essential medicine list. And single pill combination is emerging the best practice for safe, effective, rapid, and convenient hypertension control worldwide. But the RCTs are lacking. And for initiation of therapy, we have already discussed. Indian guidelines says that for a younger patient, younger means less than 55 years, we can start with the ACE or ARB, and older patient we can go for the CCB or diuretic. And in step 2 we can combine these two, and in step 3 we can combine all these three and resistant hypertension similar to other trials. Spironolactone, if side effect, then go for the eplerenone because cost is the issue. And in step 5 we can add the beta blocker, alpha blocker, and centrally acting drug or direct vasodilator. So these can be added. So undesirable drug combinations are beta blocker, ACE inhibitor, beta blocker, centrally acting drug, beta blocker with verapamil, diltiazem. We should be cautious. And ACE inhibitor, ARB, two drugs from the same class. So these should be avoided. So drug treatment strategy in CAD patient, we can go for the ACE ARB, beta blocker or CCB. Like that, beta blocker comes in the role in CAD patients, and CKD patients we can go for the ACE ARB or plus CCB, and then we can add the diuretic. For the heart failure with reduced infection, we can go for the ACE/ARB, diuretic, and beta blocker. So here comes the role of beta blocker. And in diabetic patients, we can go for the RAS blocker with a CCB or thyroid-like diuretic. So in therapeutic strategy in hypertensive patients with acute stroke, so in acute stroke, we should not reduce the BP immediately. So immediate BP lowering is class 3 if the intracerebral hemorrhage is there, and if the patient is having BP less than 220, we should not reduce the BP immediately. Similarly, in ischemic stroke also, immediate routine BP lowering is not recommended. Class 3 indication is there. And in patient with acute ischemic stroke who are eligible for thrombolysis, BP should be carefully lowered and maintained less than 180 by 105 for at least first 24 hours after thrombolysis. So special group is there. When thrombolysis is being given, then we should maintain the BP less than 180 by 105. Otherwise, the BP routine BP lowering is not recommended. If the patient is not receiving the thrombolysis, then to reduce BP by 15% during first 24 hours after stroke onset. In hypertensive patients with acute CVA, antihypertensive is recommended if the patient is having a TIA, or if after several days if the patient is having ischemic stroke. So ischemic stroke patient several days immediately for TIA. So that is exception. Otherwise, for cerebral hemorrhage, it should not be reduced less than 220, and for ischemic stroke without thrombolysis, it should be reduced only 15% in first 24 hours. So these are very specific indications we should remember, and latest guidelines are there. So monitoring and adherence, these are last 2-3 slides. For adherence and monitoring, we should at physician level we should provide information on risk of hypertension and benefits of treatment to increase the adherence, and feedback on behavioral and clinical improvement, assessment and resolution of individual barriers to adherence if the patient have any confusion about the medication, collaboration with other healthcare providers like nurses and pharmacists, and at patient level we should encourage the self-monitoring of BP, including telemonitoring, instruction combined with the motivational strategies, self-management with simple patient-guided systems, use of reminders in their mobiles or all, obtain family or social nurse support, and provision of drugs at work site. So if they're available at work site, if they forget it, take at home, they can take at work site. So health system level, what we should do, support the development of monitoring systems, telephonic follow-up, home visits, and telemonitoring, financially supporting the collaboration between healthcare provider like pharmacists and nurses, and reimbursement for single pill combination should be encouraged and accessibility to the drugs should be there. Improve the drug adherence in hypertension. The ISS 2020 also says similar things, that reduce the polypharmacy, once daily dosing over multiple times, linking adherence behavior with daily habits, providing adherence feedback to the patients. Home BP monitoring is very important, where the patient is encouraged to check the BP and then he takes the medication. Reminder packaging of medication. Packaging can be having a mention of the days. Electronic adherence aids like mobile phone or short message, SMS, or multidisciplinary healthcare team approach to improve the monitoring of adherence. And optimally, we can go for the objective indirect review of pharmacy record, pill counting, electronic monitoring devices, witnessed intake of medications, biochemically detection of medication in the urine or blood are generally preferred over subjective method to diagnose if the patient is non-adherent. So the monitoring, we should reduce the BP at least 20/10 and ideally less than 140/90. And for monitoring BP control should be achieved, target should be achieved in within 3 months, and adverse effects and long-term adherence should be monitored. And if BP is still uncontrolled, we should refer it to the hypertension. So to summarize, friends, we cannot conclude that BP target is more important or antihypertensive drug selection. Major criteria that help to decide setting of BP target and drug selection for treatment are comorbid conditions, patient's age, gender, patient's clinical condition. Although some variation occurs in different guidelines, ultimate goal is to effective control of BP to improve the outcome and better quality of life. Common sense is still valid. BP target and treatment should be based on clinical experience and patient condition. Do not lose the goal BP labels, but focus on the achieving a BP less than 140/90 in person under the age of 80. For individual over 80, we can go for the 150/90 target, and simple, no confusion, straightforward, and go for it. Thank you very much.
You see the excellent talk by Dharmendra Jain. If any suggestion, any query, please ask. Anybody have any question or query or suggestion?
Any question? Hello.
Yes, boss.
Sir, you target BP, what you show is an office BP, home BP, or the average ambulatory BP?
Sir, we have already shown a specific home BP. This is office BP. For home BP, the targets are a little less, and for ambulatory BP is also different. I have shown in the slides, and this is office BP.
So, would you like to have this target in the elderly, office BP?
Yes, sir. 150/90 is to be on safer side in elderly. The guidelines are there to say like that.
Because in practice, the office BP is most unreliable BP, and targeting this BP for treating hypertensive, how much is correct? Because the
Sir,
home
for follow-ups, I already stressed in the my slides that the home BP monitoring is best. I found it in all the patients. My patients are coming with the
recommendation assessment. They have not mentioned about whether it is this target is an office BP or the home BP.
They have given the detailed guidelines. They have emphasized and given the clear-cut guidelines where the home BP and ambulatory BP are indicated and helpful. For follow-up, for diagnosis, ambulatory BP is being stressed in all the guidelines. And for follow-up, we can go for the home BP monitoring or ambulatory monitoring. So for optimizing that. Pardon?
That means the target what you have shown is a home BP.
For home BP, sir, targets can be a little less than the office BP. It can be 130/80 that I have shown in my slide for home BP, because in office the little higher BP because of other effects is there. So home BP targets are little less, 130/80.
I have a question, Dr. Dharmendra. This is about when we advise this patient to monitor their blood pressure at home and come back with the blood pressure chart in order to,
follow up.
manipulate the drug.
Yeah.
So what kind of BP recording you recommend them? Because they always ask whether they should go for that digital one or they should go for
Digital only, boss. Digital. WHO has shown clearly this is very clear cut. There is no confusion about that. It should be only and only digital.
digital. They always have one confusion because they monitor with different devices and they find that there is a lot of disparity in the blood pressure measurement. So is there any specific means standard those monitors available in the market, or are they all calibrated up to a standard that should give you a more close measurement?
I think but for this we can help for the calibration, and that can be done in your office also. When the patient is coming, it can be cross checked with the mercury manometer, and otherwise they are all tested devices. And main important thing is that how to measure the BP, that should be taught to the patient, that he should be comfortably be sitting on the table and chair and putting the arm comfortably on the table, and then he should take in the BP, and the three readings can be taken, and like that average of both first should be discarded and average of second third readings. These are the ideal things. If the patient is following, then I think we can definitely take a very reliable BP at home. So, and he should avoid the tea and coffee and exercise half an hour before smoking and all these things, which are general for the BP measurement. These things should be kept in mind when he is measuring BP. So the reliable BP we will have for monitoring.
And next topic is dyslipidemia guidelines update in 2021. And the speaker is Dr. Ankit Agarwal, DM Cardiology. He is a senior interventional cardiologist at Jabalpur. And I think it's over to Dr. Ankit Agarwal for his talk.
Hello, everybody, and congratulations, Dr. Alok Singh, for organizing such a wonderful conference, the Heart India Conclave 2021. And I would like to come to Varanasi for some reasons. I would not able to join there, but nevertheless, it's always interesting to interact with such a learned faculty. And being a product of Banaras Hindu University, it's always a pleasure to be part of that. My topic is dyslipidemia in guideline 2021, and I am going to highlight it in a very succinct way. I don't want to take a lot of time of yours, and I must thank the Novartis people for helping me in preparing and presenting this slide structure. So dyslipidemia guideline update 2021. So broadly, yeah, so I told already. So what is the burden of atherosclerotic cardiovascular disease? LDL cholesterol, an independent and modifiable risk factor for atherosclerotic cardiovascular disease. Guideline recommendation for management of LDL. So because we know that LDL is the most common culprit cholesterol for the patients who are having atherosclerotic disease. Quantifying the unmet medical needs and limitations for current lipid-lowering therapy. And in the last few slides, I'm going to summarize what we have discussed so far. So burden of atherosclerotic cardiovascular disease, it is one of the most common cause of death worldwide. Is leading cause of death. It causes about 31% of all deaths globally, 45% of all deaths in the Europe, and 33% of all deaths in the United States. CVD also a leading cause of premature death. That is the most disheartening part. You cannot prevent all deaths, but you can prevent premature deaths, and accounts for about 6.2 million premature deaths globally every year in people aged between 30 to 70 years of age. So CVD claims more lives each year than other non-communicable disease globally. If you see, the cardiovascular disease, it causes around 18 million deaths. Cancer is 9 million, respiratory is 4 million, and diabetes is around 1.6 million per year globally. CVD remains the most common cause of death in India also. The coronary artery disease manifests almost a decade earlier in India than in Western countries. If you look into this pie chart, you can have the look is that the almost 1/4 of Indians die of some form of cardiovascular disease. The other are communicable disease, malignancies, respiratory disease, and so on and so forth. So the estimated prevalence of CVD in India was estimated to be around 55 million people. The CVD accounts for around 25% of deaths. Prevalence of hypercholesteremia in these patients varies from 10 to 15% in rural to 25 to 30% in urban populations. In the first phase of ICMR India study in India, 39% or 14% of the study population had hypercholesteremia and high LDL cholesterol in around 12%. So CVD maintains the top position of cause of death in India. This translates to heavy economic burden of the disease. IHD incidence has risen by 40.8% in the past decade. CVD affects households reported 1.5 extra per member spent in hospitals. So this is very important that it not only mortality but also morbidity. Out-of-pocket expenses are significantly higher in CVD affected households than controls by around 16 to 17,000 rupees in patient in the preceding year. Employment rates are lower for CVD affected households than control for both adult males. So it not only affects you in part of health, it affects you in terms of morbidity, your hospitalization bill increases, and most commonly, because you are in some form of disease, you are having, and that takes away your employment status also. You are more homebound, you are not able to do strenuous activity, so you are not able to work properly. So this is the economic burden which I told, which is huge. This would increase to 800 billion if 100% of CVD patients were aware and receive necessary treatment. So at present it is around 200 billion rupees, but it is going to catapult into a huge. So LDL, now coming to the topic, why it is important, why I have given this summary before, because there is a large unmet need for the people needs to be aware of, and then if they are aware of, they needs to be treated. So LDL cholesterol is an independent and modifiable risk factor for ASCVD. Long-term exposure to LDL is a key predictor of ASCVD. If you see evidence accumulated over the last 30 years, so genetic studies, prospective epidemiological cohort studies, Mendelian randomization studies, and randomized trials. So these are more than 200 studies, more than 2 million participants, 20 million person years of follow-up, and more than 150,000 CV events. Dose-dependent log linear association between the absolute magnitude of exposure and of the exposure to LDL-C and the risk of ASCVD. So it is, it has become more and more mathematical now. That means the more the LDL, the more the risk, and more is likely to be your chances of having ASCVD. So continuous long-term LDL-C reduction leads to proportionately greater reduction in the lifetime risk of ASCVD. So if you look into these charts, this has been derived from plethora of studies. We have long follow-ups, not one studies, and there are multiple model studies which have shown now beyond that each millimole reduction of LDL-C reduces the relative risk of ASCVD events by 10% during the first year, 16% after the second year, 20% after 30 years, and 1.5 year after each subsequent year. So this is what I want to emphasize, is that the risk reduction is cumulative. So it is not a one-time goal. You have to keep this patient monitoring and try to maintain the whatever the goal is forever. 5 years of risk of lipid-lowering treatment should reduce the relative risk of ASCVD by almost 25%, which is very, very high. 40 years of treatment is expected to reduce ASCVD events by 55% per millimole reduction in LDL. So these are all mathematical models you can see on the right also. So log linear association per unit change in LDL-C and the risk of CVD. So the more the magnitude of exposure to lower LDL-C, the proportion in reduction. So if you can see, if you can increase the reduction of LDL, that there is a more proportional reduction in CHT. So maintaining LDL-C exposure below the threshold reduces plaque burden and prevents the development of ASCVD. This is although the busy slide, but what it tries to emphasize is that the more the robust reduction in the LDL and more maintained for over years, the risk reduction is cumulative and it keeps on accumulating. So once the cumulative LDL exposure threshold has been exceeded, the total plaque burden continues to enlarge in proportion to the circulating plasma LDL concentration. And the incidence of myocardial infarction doubles with each increase in exposure to the same plasma level of LDL-C. Next, please. Okay. Guideline recommendation for management of LDL-C. So where we stand today in 2021, this is how it is. So 25 years of evidence prove that benefit and safety of progressively lowering the LDL. So it started way back with ATP1 in 1998, which shows that the LDL should be around 130. Then came ATP2, which shows that the LDL should be maintained around 100. Then these are 4S, lipid, care, HPS, prove it, TNT, improve IT. They said that the LDL should be further moved down, and ATP3 also, which says that the LDL goal should be 70. Then ACC-AHA came in 2012, which says it is 70. Then after the 4-year trial in 2017, the ACC said it should be further lower to 55. 2018, it again went up a little bit, and now as of now we know that it should be around less than 70 and if possible less than 55. So this is the 2019 ESC and the 2019 guideline on the prevention of severely recombinant lowering LDL levels. So you can see low, moderate, high, and very high. And this is the treatment goal. And 50% reduction from the baseline. So first goal is 50% of the reduction in the baseline, and then you have to target it below 55 if possible. So this is very high. What is very high? Low, moderate, and high risk. Those people who are very high, that means the ASCD clinical imaging score is more than 10. Family history with ACMD or with another major risk factors, severe CKD, diabetes and target organ damage, or greater than 3 major risk factors, or early onset of type 1 DM or long-term duration of type 2 DM. You have to bring the cholesterol level to 55. So these are the patients who are having, supposedly a patient has an episode of an angioplasty, or a patient had a clinical MI, although not treated with angiography or angioplasty. If he falls in this criteria, he is actually very high, and the LDL should be around 55. If the patient is high to moderate, you can still have, you can still target around 100 to 70. These are the scores which are around 5 to 10, markedly elevated single risk factors, family history without any major risk factors, moderate CKD, diabetes mellitus without organ damage with diabetes duration greater than 10 years, or other additional risk factors. And the score if low, you can still target the LDL, not in a very, very, very robust manner, but you can be little lenient in getting the LDL levels. So Lipid Association of India expert consensus statement on management of dyslipidemia in India in 2016 has said that the treatment goals and statin initiation thresholds according to ASCVD risk categories: very high risk, moderate risk, and low risk. The treatment goal of LDL cholesterol is less than 50, and non-HDL cholesterol is less than 80. For high risk, it is less than 70, and the non-HDL is less than 100. So there is a difference of around 30 milligram per DL for LDL and non-HDL cholesterol. Consider drug therapy. So in very high risk LDL cholesterol, the statin should be given in all patients who have LDL, preferably in all respective of LDL, although you say that if it is more than 50. In high risk if it is more than 70, and the goals should be met at any cost. After an initial adequate non-pharmacological intervention for at least 3 months, which is set in all these patients, irrespective of drug therapy. So proposed low density lipoprotein for secondary prevention in familial hypertension in India with focus on PCSK9 inhibitor monoclonal antibodies, expert consensus statement from Lipid Association of India. The LAI conducted a series of 19 meetings among 162 lipidologists in 13 cities throughout India over a period of around 1 year. And more aggressive LDL goals are needed for prevention of ASCD in India. So less than 50 in all patients in secondary prevention, or very high risk primary prevention. Optimal goal, less than 30 milligrams, category A, extreme high risk patient. This is coronary artery disease or familial hypercholesteremia. And less than 30, category B, extreme high risk patients. That means the patients with coronary artery disease plus diabetes and polyvascular disease or greater than 3 and organ damage, recurrent acute coronary artery within 12 months despite LDL less than 30, and homozygous familial hypercholesteremia. These are patients who are, with focus on, they require more robust, even less than 50. Optimal goal is 30. So this is what I emphasize, that for secondary prevention in familial hypercholesteremia in India. So proposed for secondary family, this is what I discussed before, and in that slide, and this is an algorithm for this. Quantifying the unmet medical need with current lipid-lowering therapy. So percentage reduction in LDL varies across different guidelines recommended lipid-lowering therapies. So if you see this, what are the various drugs we have in our armamentarium? We have statins, we have bile acid sequestrants, we have ezetimibe, we have PCSK9 inhibitors, we have mipromorsen, we have lomitapavir. So now if you see, studies are considered a foundation therapy based on guidelines. So it causes in different studies the LDL cholesterol reduction from 18% to around 55%. Ezetimibe, when added to statin, reduction of around 21 to 37%. PCSK9 inhibitor, LDL reduction of the most robust LDL reduction when added to high intensity or maximum tolerated statin. But this is injectable, as you can see, and these are all tablets. Bile acid sequestrants, they causes around 20% average reduction in LDL. Mipromorsen causes around 33%, and lomitapavir causes around 45 to 50% reduction in the. While statins were a breakthrough, stagnation of further advances in LDL therapy plateaued the decline in CV mortality. Now, mortality rates from CV disease in the US per 100,000, if you see. So the decrease, from 2010. So there is a tremendous decrease with the introduction of statin. The graph actually, remarkably came down, but it plateaued around 2010 to 2015. So there is limited treatment options. Cholesterol management was limited to suboptimal agents, and lifestyle changes prior to the availability of statins in 1980s. Widespread adoption of statins after addition and other advances in CV, significant decrease in mortality were observed. You can see this graph. And reduction in CV mortality has plateaued with significant enduring unmet need, requiring a fresh wave of innovation to advance LDL management. So this is how it is. You can see, and the red box shows that it has plateaued now. Da Vinci study demonstrated current gaps in reaching 2016 EAS LDL cholesterol goals. Overall, 50% attained overall risk-based 2016 goal. Low risk people attained around 60%, 63% of the low risk people attained the goals, and very high risk attained only 40% people actually are achieved the goals which are required for the LDL cholesterol. So overall, if you see, only 1/3 of the patients have achieved the goal. In patients with established ASCVD, 2009 goals attained was approximately half that of 2019. So probably, with the guidelines becoming more and more stringent, the goal of attainment has become less. So if you see the people who have achieved the LDL cholesterol goals in 2016, in 2019 the goals were achieved much lesser. The potential reason for failure to achieve the guideline recommended LDL cholesterol levels are lack of healthcare physicians' familiarity with the guidelines. We still have inertia. If you see the cholesterol, my cholesterol LDL is 50, the people tend to stop the statin, or they say that your goals are achieved. High cost of medications. If you have novel drugs like the injectable, the cost is humongous still. Patient reluctance to be treated with high intensity lipid lowering therapies, and concern about a statin related advancement. The authors conclude that even with greater utilization of non-statin lipid is likely needed to reduce these gaps who are patients at highest risk. So despite being the foundation therapy, greater than 50% patients requiring statins remain undertreated. So overall, if you see, no statin, lower than recommended intensity, and treated appropriately. If you see proportion of patient treated, overall it is 25%, 32%, and 42%. Primary prevention, it is treated appropriately is only 36%, and secondary prevention, the treated appropriately is still higher. It is around 50%. Risk-based LDL goal attainment was not achieved by 2019 in patients on lipid-lowering therapy. This, which we have discussed, time and again. If you see 2016, the risk-based reduction was higher, and it has reduced dramatically in 2019 because the goals have been reset. Though statin therapy is effective in lowering LDL cholesterol, there still remains residual dyslipidemia. The REMAIN study, a multi-center observational prospective cohort study of lipid profiles pre and post statin therapy among adult patients with confirmed diagnosis of first acute coronary event. If you see, the LDL cholesterol is effective from. There is still, if you see this, there is still a lot of dyslipidemia remain even after treatment with statin. The large gaps exist in guidelines recommended LDL cholesterol achievements in ASCVD patients, and this I have told already that only around 40 to 50, at best 50% patients actually are able to achieve the targeted goal of LDL cholesterol even after giving high dose statins. So what are the current limitations of current LDT? Multiple factors contribute to the risk, lack of effective lowering of LDL cholesterol in patients receiving statin therapy. One is inter-individual variability in LDL cholesterol reduction. So 26 to 52% patients fail to achieve greater than 50% reduction in the LDL despite treatment with high intensity statins. Second, statin intolerance. Around 1/3 patients receiving statins probably due to muscle-related, lot of myalgia. Then treatment discontinuation, 40 to 70% patients discontinue with therapy within 1 year of initiation, with various reasons, which is sometimes beyond discussion. And switching between statin therapy, 20 to 24% of patients are switched to different statins. Switching has been associated with significantly greater CV risk. This is very important. If the patient changes physician, the statin also changes, and that also increases the risk of CV events. So inter-individual variability in LDL cholesterol. In LDL cholesterol reduction for statin therapy is due to several genetic and non-genetic factors, and these are and the non-genetic means older age, male gender, higher BMI, and lower HSCRP levels and lower LDL baseline levels. And these are some genetic factors like apolipoprotein encoding genes encoding proteins involved in transport, uptake, and metabolism of statins, and Caucasian ethnicity. Inter-individual variation in LDL cholesterol reduction of statin is independent of statin dose intensity. That is very important. It is not that the patient are underdosed. That's why it is. Some people achieve the goal at lower dose of statin, and some people are not able to achieve the highest dose of statin. So the degree of LDL reduction in dose dependent and varies between different high intensity treatment, lower LDL by 50%, moderate intensity treatment by 30 to 40, and low intensity treatment by less than 30. Results from the Voyager meta-analysis showed an individual variation independent of statin intensity. That is very important. Even among patients those who have high dose statins, 40 to 45% patients with atorvastatin 80 mg, 26% with rosuvastatin 40 mg, with simvastatin 80 mg failed to achieve greater than 50% reduction in LDL cholesterol. This is very important part. Sometimes we tend to forget that there can be other factors which play a role even when you have gone with the robust dosage of the best possible drug. Adverse event was seen was one of the major reasons for discontinuation of switching to another statin. Although statins are generally well tolerated, statin adherence is poor in clinical practice with lot of variation. 30 to 75% discontinuation rate within 1 to 2 years of treatment initiation, with adverse event with the most important reasons. So reasons for switching statins in a cross-sectional self-administered internet-based survey. If you see, this is the reason is one is cost, the second is side effect, and third is lack of efficacy. In current use of former users, cost, the side effect is the most common, and second is lack of efficacy. And if you look overall, current user and former users, these two things, the cost and side effects, are the major cause. Changes to statin regimen because of side effects or abnormal evidence by statin use in state survey. This is patients who continued statin therapy were more likely to have regimen adjustment than those who discontinued statin therapy. So statin intolerance is frequently attributed to statin-associated muscle symptoms, which are experienced by around 25% patients receiving statins. The definition of statin intolerance varies between guidelines. Generally, statin intolerance is a clinical syndrome characterized by the inability to tolerate multiple statins with either objectionable symptoms or abnormal laboratory determinations that are temporarily related to statin treatment, and reversible upon statin discontinuation, but reproducible when re-challenged. This is very clear cut. So it has to be it is reversible on cessation of statin and reproducible once you restart the statin. So statin intolerance is associated lower likelihood to achieve LDL treatment was high severity and higher health care costs. So due to side effects or abnormal laboratory values, about 2/3 of patients on statin are willing to switch to other statin or non-statin treatment. So if you see this, percentage of patients, around 50% patients stop statin due to side effects or abnormal lab results and do not take anything to control cholesterol. I have not communicated with doctor about decision to stop statin. Cholesterol, 42% patient cholesterol under control with current approach, willing to try another statin to better control cholesterol. And these are the patients, and the patients who are currently willing to try a different statin, 65%, and willing to switch to a non-statin statin to help control cholesterol, reported that their cholesterol is not under control at goal or are unsure. This is a very important slide if you see this. So statin discontinuation rates are higher after MI in Medicare beneficiaries. So this is a very important from US. If you see the patients who are on who are Medicare beneficiaries previously hospitalized on MI, the same drug 50% reinitiated statin and 50% did not reinitiate statin, and around 80%, 84% continued statin, and 15% actually discontinued. In this 15%, 50% again reinitiated statin, and 47% did not reinitiate statins. This is very important slide. So only few ASCVD patients on statins and with LDL cholesterol greater than achieve ezetimibe or PCSK inhibitor in the real world. So in the statins they receive, if they do not, you add ezetimibe or you add PCSK9 inhibitors. So multiple hepatic challenge, a more frequent use of PSN, the affordability, not cost effective at the current price. Price of Aleulocumab would have to decrease from its original cost of $14,562 annually to be cost effective versus ezetimibe. Logistics, and it is around 12 to 60 injections per year. Summary. So the guideline for the management of LDL have become more stringent with lower LDL targets over the years. Each millimole reduction in LDL reduces the relative risk of ASCVD events by 10% during first year, 16% after second year, and 20% after third year. In patients with established ASCVD, 2019 goal attainment was approximately half that of 2016, which I said, because the guidelines have become more stringent. The factors responsible for not attaining LDL cholesterol goals are multiple. Inter-individual variability in LDL reduction, statin intolerance, treatment discontinuations, and switching between statin treatments. Adjunctive therapies are needed to achieve effective and sustained lowering of the LDL cholesterol and prevent the progression or development of CV events. Thank you. Boss, Dr. Alok? Hello? Yeah.
Thank you, Dr. Ankit, for a nice talk. Is there any question? I think Professor Sanjay Kumar will ask one question.
Yeah. Yes, sir.
But Ankit, it was a brilliant presentation. I just have a few questions for you.
Yeah.
One question that you mentioned about the patient with the high risk. The target to achieve the LDL is as low as
30. Less than 50 or even 30, sir. Indian guidelines says it is 30.
So when you are driving the dose of your target, do you have more adverse effect, something like myopathy and type 2 diabetes onset or even weight gain and all that kind of thing?
Sir, the most common side effect we feel, we encounter actually is myalgia. And myalgia actually doesn't recommend or doesn't warrant this discontinuation of statin. But the people, those people who tend to have intolerable myalgia, we need to cut down the dose. And when you cut down the dose, actually, you are not able to get the desired LDL cholesterol. And it is a myth that switching from one statin to another statin, the chances of having myalgia will decrease or change. Generally, it is a class effect. If the patient doesn't tolerate one statin, is not going to tolerate another statin. And the most common thing that you have to keep in mind is that switching the statin actually increases the CVD events. The exact logic is that the lipid lowering profile changes with switching of the statins. And second thing is that the tolerability doesn't increase with the changing of the statin. So if you ask me serious side effect of the statin, I have encountered only one in which there was a very high rise of CPK after statin, and we have to, it is like the patient was going into myoglobinuria sort of condition, and we have to stop statin, almost going to renal shutdown. Otherwise, generally the side effects are less, and if you do a good counseling, they are tolerated by the patient. Regarding new onset diabetes in patients who have oral statin, so generally the patients who develop new onset diabetes, we are concerned in those patients for new onset diabetes which are used for primary prevention. When you are using it for secondary prevention, if you are treating actually 15 individuals, one individual over a period of years can develop a diabetes. But when you are doing it for secondary prevention, which is high risk, which you have asked, the new onset diabetes is not in our mind. It's in our mind is that you have to achieve the target goal by anyhow. So, getting a diabetes or discovering a diabetes later on, you tend to discover a diabetes in follow-up in a lot of these patients in a subsequent years, but that is because statins or that is because of multiple factors the patients are having is hard to tell. But that should not preclude you from giving statins to this patient.
Okay, thank you. And there is another question about the switching the statins.
Yeah.
Side effect does not change. But however, if you to achieve the target, of LDL level, one statin, like supposing you started patient on Atrova, and up to you did not achieve the target, would you switch to rosuvastatin 40 and you think you will achieve?
Sir, that is what I'm trying to tell. The most important part of not achieving the goal, if you see this, is the inter-individual variability in lipid reduction, and which has little to do with the type of statin. It is, individual's body is not responding. These are the factors, if you see. So if you change the statin class, suppose if you change from Atorva to rosuvastatin, there may be an incremental decrease in LDL cholesterol, but still, if the patient is not responded to high dose of one statin, the chances of responding to that another class of statin is less. That's why I said you have to add like ezetimibe, or you have to go for PCSK9 inhibitors for achieving the goals in these patients.
Thank you. And the last question, this is about whenever we look at the lipid profile of this patient with a coronary artery disease, we find they have high cholesterol, LDL, and even triglyceride, and tend to have a low HDL, and HDL is a cardioprotective. So, do you have any pharmacological manipulation, like using niacin or something, to help this bump up this to help these patients?
So, if you look in the evidence-based medicine nowadays, decrease in HDL increases the CVD risk, but increasing the HDL does not decrease the CVD risk. So all these therapies, if you so for nicotinamide or niacin, whatever you may be, your primary target is actually LDL. Once you achieve the LDL, the other targets become secondary. You can go for triglyceride reduction if it is more than 450 in these patients. Otherwise, anything which actually decreases TG will increase HDL. And when you decrease LDL, actually you decrease TG and you increase the HDL. So your target should be bullseye. You have to target the LDL. If the patient is suffering from familial hypertriglyceridemia, then it becomes a second different ball game altogether. And then you have to go for the primary treatment of triglyceride. Otherwise, your target should be LDL. You should not much be bothered by HDL, and you should not try to target HDL in all these patients.
Okay, thank you, Dr. Ankit, for nice presentation and question answer.
Thank you, sir. Thank you.
The next topic is diabetes mellitus with CAD management considerations. The speaker is Dr. Deepesh Agarwal, DM Cardiology. He is Senior Interventional Cardiologist at Mahatma Gandhi Medical College, Jaipur. So over to Dr. Deepesh Agarwal.
So thank you very much, and thank you, Heart India Conclave, Dr. Alok, and chairpersons over there. And I always feel pleasure to be there in Heart India Conclave to present. So after this wonderful talk, I'll try to concise my lecture, and I'll give a short review, and I'll try to finish within 10-minute time.
Oh, yes.
So can you see the slides, please? Dr. Alok?
You are having your slide with me. You will share now.
Yeah. So can you see my slides now?
Oh, you have started screen sharing, but your slide is still visible. You are visible, but your screen is not visible.
Okay, so let me share again.
Opened your slide.
Yeah, I opened my slide and just a minute. Now, can you share? Can you see now?
Now we can see.
Okay. So my topic is basically diabetes and CAD management, and you all know that CBD is a significant global burden if you look. And the data of 2012, if you see 56 million of global death is there, and out of that 31% is because of cardiovascular diseases. And 74 million are because of CSD, and 67 million deaths were due to stroke. And if you see the diabetes prospect, in 2000 it was predicted that there would be 450 million people will be having diabetes by year 2030. And if you look the data of 2013 and predicted data of 2035, there will be almost 50% increment of diabetes in 20 years period, and the maximum number of increase will be seen by Southeast Asia and African countries. And if you talk about India, then 70% increased number of people with diabetes will be seen in India and Southeast Asia region. If you look at global epidemic burden of diabetes, the one person dies every 6 seconds from diabetes and its complication. It is very important. And the relative risk, if you see the diabetes approximately increases the risk of death by 2 times. All cause mortality 1.85 and 67% because of CV mortality. And if you look the data for the India, so India is one of the 6 countries of Indian International Diabetes Federation Southeast Asia region. And if you see the total prevalence of diabetes in India is almost 10%. So it is quite high. And southern state of the India are having more diabetic population as compared to middle and north India. And the ratio is almost same in male and female. So the diabetes increases the risk of death event in all form of vascular disease, like in coronary heart disease, cerebrovascular disease, ischemic stroke, and other vascular disease almost 2 times. And the significant loss of years is, if you see, this is seen in both men as well as in women, and the risk increases with increases of the age. So why it is important to discuss the treatment of or the management of CAD and diabetes? If you see, if a person is having a stroke or myocardial infarction along with diabetes, then the hazard ratio just doubles from 3.5 to 6.9. Similarly, if a person is having only MI or stroke, and if they are having diabetes along with that, then the hazard ratio increases from 2 to 3.7 or 3.8. So the diabetes itself increases risk of mortality, thus doubles or even more than that, and that is in both age as well as sex-adjusted ratio was seen in this age group. So how CAD is different in diabetes? We all know that CAD is having multivessel disease in patient with diabetes. The more distal lesion and the more diffuse lesion we see in diabetic patient, they usually present with silent ischemia and myocardial infarction. More younger population is affected with diabetes, and worse outcome despite after revascularization is seen with diabetes. That means increased risk of restenosis after PCI, even with putting a stent or without putting a stent. And the worst perioperative and long-term outcome are seen in patients with diabetes. along with CAD. So the CV screening, if you talk about where we should screen in patient with diabetes. So in asymptomatic patient, it is not recommended to screen routinely for coronary artery disease because it doesn't improve outcome. Even if you see the coronary artery disease and patient is asymptomatic, it will not increase outcome as long as the risk profile, risk factors are treated. Then only when to consider the investigating the CAD where the atypical cardiac symptoms are present like unexplained dyspnea or chest discomfort which were not explained by other things. And otherwise, sign and symptoms of associated vascular disease like carotid blue if confined, TIA, stroke or claudication if you feel, or history of peripheral artery disease. Or if you find ECG abnormality suggestive of prior coronary event like old myocardial infarction and all. In this scenario, we should search for coronary artery disease in patient with diabetes or if they are asymptomatic. Otherwise, routine screening is not recommended in diabetic patients. So coming directly to management part. So according to American Heart Association in clinical management of stable, I am talking about stable coronary artery disease in diabetic patient. So first, this is regarding antithrombotic treatment or antiplatelet agent in diabetic coronary artery disease, stable coronary artery disease patient. So why it is important in diabetic patient, we usually see generalized prothrombotic state, and that is caused by the both altered coagulation and altered platelet function. There is hypercoagulability and more thrombogenic state, more inflammatory state, which causes progression of atherosclerosis and thrombotic event. So with trial, if you see the aspirin alone, if you use in patient with stable coronary artery disease, that shows the lowest risk of bleeding if you use the aspirin alone. But there is high residual platelet reactivity seen with increased cardiovascular risk. So if you use aspirin alone, this is the risk. But if you use the clopidogrel alone, that is seen in Capri trial, so that showed the decreased cardiovascular risk without meaningful increased risk of bleeding versus aspirin alone. So with Capri trial, if you go in patient with stable coronary artery disease with diabetes, the clopidogrel showed benefit over aspirin in patient with CAD and diabetes. Then comes the combination of aspirin with clopidogrel or ticagrelor, which showed decreased cardiovascular risk if you combine both, but with the increased risk of bleeding. So the combination therapy in diabetic patient with CAD is recommended with targeting patient with additional risk factor if they are having or low risk of bleeding if they have. So the combination of these two should be given. Then the latest with the COMPASS trial, if you see the combination of aspirin with low dose of rivaroxaban 2.5 milligram BD dose that showed the decreased cardiovascular risk in diabetic as well as in non-diabetic, but with slight increased risk of bleeding. So again, this combination should be preferred where you think the high coagulation or high thrombogenic state is there in patient with diabetes. So this is about the antiplatelet therapy in patient with coronary artery disease and diabetes. Then comes the blood pressure management in patient with coronary artery disease and diabetes. So the main issue, if you see the blood pressure, is the coexistence of hypertension in diabetes that increase risk of myocardial infarction, stroke, as well as all-cause mortality. So the target is basically a debatable issue till now, because latest with the sprint trial that has been shown, the lesser is the blood pressure, better is the outcome. But again, in a sprint trial, diabetic population was excluded, and the pre-diabetic patient were included. And in sprint trial, they have shown the systolic blood pressure of less than 120 showed a beneficial effect. But the other trials like on-target trial and transient trial, invest trial, that showed the blood pressure of strict target of blood pressure showed a poor outcome, especially cardiovascular outcome. So the target of 140/90 is still in most patients is considered to be good, but again less than 130/80 is recommended if additional risk factor for stroke or microvascular complications are there in diabetic CAD patient. So regarding the therapy, what are the drug options we have for diabetes and hypertension management? We have ACE inhibitor and ARBs. So the first line therapy is still after HOPE trial is ACE inhibitor. And first line therapy is ACE inhibitor or ARB for decreasing cardiovascular risk in patient with CAD is still there. Long-acting thiazide diuretic that showed good cardiovascular risk reduction, but again, slight derangement of glucose level is there. Calcium channel blocker, especially non-dihydropyridine group, should not be used. But again, amlodipine or this group has good cardiovascular risk reduction along with effective anti-anginal activity has been seen with this group of drug. Then aldosterone antagonist particularly is benefit in patient with prior myocardial infarction or LV dysfunction, along with the hypertension if it is there, or borderline potassium level is there, then the aldosterone antagonist should be used in patient with diabetes and hypertension in CAD patient. Regarding use of beta blocker, so in beta blocker has been used in many trials, and they did not show mortality benefit in uncomplicated patient with stable CAD. And on top of that, if we are using non-selective beta blocker, vasodilator beta blocker, they also causes metabolic derangement, and it has been recommended to choose vasodilating beta blocker for less adverse metabolic event in patient with diabetes and CAD. Then lipid management is important in patient with CAD and diabetes. So it has been talked in elaborated manner by Dr. Ankit that lipid is very important in CAD management. So here the guideline, what they are saying, the atherogenicity of lipid is very important. And in diabetic patient, we usually show high triglyceride level, low HDL level, and many a times normal or low LDL level. But again, the small and dense LDL particle are very important in diabetic patient, and these are the main reason for cardiovascular events. So the LDL is still low, but again, lower LDL is recommended in diabetic patients. So try to use highest possible tolerable dose of statin in patient with the diabetes and CAD. And that is the cornerstone of therapy for secondary prevention as well as primary prevention. But again, if a high risk patient, if we are not able to achieve a target LDL cholesterol level of less than 70 in high risk group, in that case, we can use additional cardiovascular for reduction. We can use ezetimibe or PCSK9 inhibitor. Like the PCSK9 inhibitor showed the maximum and robust LDL reduction with the evolocumab or elastigimab in Odyssey or Format trial that was used in both diabetic as well as in non-diabetic population, and that showed almost 27, 25, more than 25% reduction of cardiovascular events. And then use of niacin is not recommended. Like niacin is used basically to increase HDL cholesterol, and HDL cholesterol is said to be a cardioprotective bucket. But again, in many trials, especially in AIM-HIGH trial and other trial, the use of niacin didn't show morbidity and mortality benefit in patient with dyslipidemia, those who have who has increased HDL cholesterol even with niacin therapy. Then regarding use of fibrate in patient with dyslipidemia, especially with hypertriglyceridemia, the recommendation of triglyceride is if it is more than 500 milligram per deciliter, then you can use drugs to reduce the risk of pancreatitis. But again, the targeting triglyceride as a first line therapy is not recommended still in patient with coronary artery disease. But recently in fish oil group, omega-3 fatty acid group, where they have used icosapent pentanic ethyl in 1 gram BD doses in patient those who have triglyceride level of more than 135 to 499 or 500, despite maximal statin therapy in those cases, there were a reduction. So the non-statin therapy, only non-statin therapy, you can say, or non-LDL targeting dose of icosapent ethyl, basically omega-3 fatty acids, shown to be beneficial in patient with diabetes and CAD and dyslipidemia patient to reduce cardiovascular events. And apart from this antiplatelet therapy, antihypertensive drug, dyslipidemic drug, the glycemic control is still important part in management of diabetes with CAD. So what are the target level of sugar we could achieve? So there are, it has been seen that the target of hemoglobin A1C is less than 7 or less than 6.5 in young healthy individual is recommended, where the life expectancy is around 20 years. And it depends upon the preference and capacity of the individual. But then if a person is older, so tight glucose control is not recommended because there are more chances of hypoglycemia and cardiovascular event has been noted. So in elderly population, it is recommended to have hemoglobin 7 is around 8 or less than 8. So we have a number of drugs to control blood sugar, and the drugs have both cardiovascular as well as non-cardiovascular effect. So for diabetes control, metformin is a class 1 recommendation.
Out of time, so please try to be.
So I think metformin, SGLT2 inhibitor, GLP-1 agonist, thiazolidone, DPP-4 inhibitor, these are the molecules which are in use. So SGLT2 inhibitor is basically nowadays is getting more preference because it has significant reduction of cardiovascular morbidity and mortality reduction, apart from heart failure hospitalization risk. Then GLP-1 and receptor agonist again showed cardiovascular benefits. So these are the molecule which we should use in diabetes and CAD populations. And management of stable angina, beta blocker, calcium channel blocker, long-term nitrate, and ranolazine, they have effect, but they no anti-anal drug reduce mortality or morbidity in anal patient. Then about few lines about revascularization is both surgical and percutaneous revascularization outcome are impaired in setting of diabetes. And even if we revascularize these patients, the end result is not as good as in patient with non-diabetic population. But again, diabetic population have multivessel CAD, left main disease. So CABG is preferable over PCI in diabetic population. That showed, and CABG group, Lima group already showed a significant benefit over the venous graft. So I think I should with the improved IT trial, the addition of ezetimibe had been shown to be effective, and similarly, the impact of intensive glucose control on macrovascular event has varied in major trials. So the different class of diabetic drug has been associated with different effect of cardiovascular outcome. So this should be kept in mind. The SGLT2 inhibitors are the drug which is already talked about. So the optimal medical therapy remain the mainstay of CAD care in diabetic patient, whether primary or secondary prevention is there. Surgical and PCI revascularization outcome are less favorable in diabetic population as compared to patient without diabetes. And in multiple trial, coronary artery bypass graft has been found superior to PCI in respect to means and need for subsequent revascularization. So this is basically management strategy: anti-anal therapy, BP control, statins, metformin, SGLT2 inhibitor, aspirin. If it is not controlled, then only go for revascularization in patient with diabetes and CAD. Thank you. Thanks a lot for listening.
Thank you, Dr. Dipesh, for such a nice elaborate lecture. Is there any question? I think.
Dr. Alok, I have one point to just add. I congratulate Dr. Dipansh and to you and the whole team for this excellent academic feast which you have organized already. And this was in continuation of the previous question which Dr. Sanjay has posed for dyslipidemia. I just have one small comment for Dipansh, as he has already mentioned that in diabetic patient, when we are dealing with their dyslipidemia, most of the time, first and foremost thing that after control of the target LDL level, but the target LDL level which now the Indian Lipid Association Society recommends of going up to 50 milligram per deciliter. It's very difficult to achieve by high dose statin therapy, and adding on the ezetimibe is a good option. But many of our patients, they're left with hypertriglyceridemia in spite of better control with diabetes also. The role of fenofibrate has already been documented by endocrine societies in these patients. But I just want to ask Dr. Dipansh that what is your take on patients to achieve such a stringent goal of LDL 50 with if the triglyceride is also raised, adding on fenofibrates or niacin group of drugs, though we see very less the effect of statin induced myopathies, though the myalgia factor is there, but it is not really derived that whether this myalgia is because of exactly statin induced or there are many more factors like vitamin D deficiency, and many of our patients, they do have a muscle associated symptoms, though the muscle associated symptoms are attributed to statin therapy. So what do you suggest that in such patients where it is difficult to achieve and we are our hands are cuffed because PCSK9 is such a costly drug that we are unable to use in our patient in day-to-day clinical practice?
So I think this is always a debatable issue whether to control triglyceride level in patient with the dyslipidemia and how much benefit we could get with the use of drugs to control triglyceride. So all the trial, whatever trial we have, niacin is basically is out because the increasing HDL and using niacin tolerance is important issue. So using a high dose niacin is very difficult to tolerate because of untoward side effects. Then to control triglyceride, if you want, so more than 135, where even after
Because
a high
in
dose of
practice,
statin, if you are not able to,
the
then the use
office
of
BP
omega-3 fatty acid is the only non-statin drug we can say which showed a significant benefit in terms of morbidity as well as mortality. But to control triglyceride with the fibrate is we can control triglyceride with the fibrate, but the trial doesn't show mortality benefit with the use of these molecules. So I think maximum tolerable dose of statin is the drug of choice. If you add, then ezetimibe is other drug which you can add, and then if you are not able to control, and if you want to control triglyceride level, then the omega-3 fatty acid, the molecule which you should prefer over fibrate and other molecules to control triglyceride level.
Okay, thank you.
Thank you very much.
Thank you, Dr. Deepesh.
Thank you, Dr. Alok, and thank you, for this wonderful meet.
Next speaker is Dr. Rajni Sharma. He is going to speak on perioperative cardiac risk assessment in patients undergoing non-cardiac surgery. He is a senior interventional cardiologist at Narayan Hridayalaya, Gurgaon. Now over to Dr. Rajni Sharma.
Good afternoon, everyone.
Please share your slides.
Somebody has to stop sharing.
Okay, you start. Now you start sharing.
Yes, boss. Yes.
Slides are visible now. Make
Visible now? Okay.
it.
So, good afternoon, everyone. And I thank you personally, Dr. Alok, for inviting me and having me for this particular talk, which is very relevant, and we have been called every day, every hour for some or the other non-cardiac surgeries, and see the patient can tolerate that surgery and give our fitness from cardiac point of view. So the topic is perioperative cardiac risk assessment in patients undergoing non-cardiac surgery. So as we have seen in clinical practice, as data has shown that in perioperative generally deaths, whatever we have seen, the most common cause always has been turned out to be cardiac, and major adverse events including MI and heart failures or devastating arrhythmias. So the majority what we see is perioperative ACS, that is MIs, and the thing in this is because they don't present the way we see MIs in routine practice when they are not undergoing any surgery. They generally have atypical symptoms, and the prognosis is worse than what we do. After treatment also, we don't get the result what we achieve in normal ACS patients. I apologize for all these technical which whatever is coming, and I don't know much of these things to do. I think most of the doctors will not be knowing technical thing much. So I will start off with the perioperative cardiac risk assessment in patient undergoing non-cardiac surgery. As I said, these patients when have MAS during this this perioperative period, the prognosis will be worse than what we see routine in cardiac patient, what we are seeing day-to-day life. So when we are giving clearance to these perioperative clearance for these surgeries, certain things and certain risk factor we have to quantify and see how we are going to manage best, so that that particular patient tolerate that surgery and goes home well. So generally we target what all things and what all risk we should not have during the perioperative period, which are devastating for the patient's life, is like having a myocardial infarction, heart failure, then hemodynamically unstable arrhythmias, patient going for cardiac arrest, and sometimes patient can have complete heart block. So when we see for all these risk factors, we have to evaluate the patient personal risk, whether a person is having already a cardiac disease, whether is already patient having some arrhythmia, like most commonly we see atrial fibrillation patients going for some or the other surgeries. Then what particular surgery that patient is undergoing, whether that particular surgery itself has a low risk or high risk in view of cardiac hemodynamic changes during peri-surgery period. So if we club the patient risk and the surgical risk, and we, after clubbing that, we need to see what are tests we need to do that should justify our testing also of like before surgery. We have to evaluate, not in the routine way we evaluate any particular patient for primary or secondary prevention in cardiac diseases. Here we have to balance, because patient has been admitted for particular surgery, and now we have to risk stratify and make him go smooth for that particular surgery. So all these risks we have to calculate, adjust the medications as per requirement, and manage the whole perioperative period. So if we talk about the guidelines, so we the recent one is the only 2014 both guidelines came. American Association Cardiology as well as European Society gave in that time. So a lot of things has been changed since then. New data has come. The technology of stents have changed. So sometimes we need to balance both the things, what guidelines are saying and what are in clinical practice, how we are seeing, and what the importance of that particular surgery and what urgency is there in that particular surgery. Sometimes clinical discretions come in such scenarios. So if we consider for the various risk models, what we all consider among all these 3-4 various risk models, most commonly we are using is a revised cardiac risk index. And from the anesthesia side, they generally use the ASA class. And when anesthetist thinks they are falling into the class 2 or above that, then they consider for cardiac clearance. And cardiology clinically see clinical risk factor through this RCRI. So in that we need to look for the whether patient is already a ischemic heart disease patient or recently has any MACE event in the past. If major MI, then past 2 months, or if stenting has been done, then within 6 months we have to consider in view of the medication, especially dual antiplatelet, what he or she is taking. Then patient is already LV dysfunction patient, had previous recent heart failure, decompensated heart failure, got admitted in hospital. Patient has already had any vascular event in the form of stroke or any previous TAI. Renal dysfunction, especially very important. If somebody is already having CKD above stage 3, we need to consider as a high risk, and diabetes mellitus, and patient is taking insulin for glycemic control. So these are various 5 factors. Clinical strategy we have to make, like in which risk strategy patient is falling, and then consider to give clearance. So we have seen those who are having more than or equal to 3 risk factor. Among these, they have more than 5 to 6% of MACE event rate, which is quite high. And those who have just 1 or 2 risk factor are fall into the intermediate risk. So this is the clinical risk what we have to see. These cardiac parameters already I told. If patient is already on CKD patient already LV dysfunction patient and having recent heart failure admission, then we need to see if surgery is non-urgent, can we delay that till patient comes out of this decompensation and all his LV dysfunction medications has been properly optimized. So all these factors we have to see. Patient with cardiomyopathies, definitely we have to see for HFpEF also, where ejection fraction definitely is not low, but patient had a diastolic heart failure recently. How we are going to, because in this HFpEF we don't have much of options to stabilize patient apart from getting treatment with diuretics during this perioperative period. So all these things we have to see. If patient is already a valvular disease patient, then we have seen obviously The left-sided valves have bad prognosis. Right-sided are not that significant unless and until patient is having severe PH or RV dysfunction. Otherwise, the left side always considered like on prime basis to have safer perioperative period. Then stenotic valves definitely going to change more hemodynamics, then regurgitations are generally better tolerated. So all these factors in cardiac scenario we consider, because while giving that sedation by the anesthetist and having pro-inflammatory, pro-coagulant state in perioperative period, there is a lot of hemodynamic changes in the form of arrhythmia, tachycardia, getting hypotension, and lot of volume shift if it is a very extensive surgery. So all these factors are going to definitely change patient cardiac scenario. And this is all about what talked is the clinical scenario of the patient, in which risk category the particular patient is falling. Then we definitely need to look for the surgery under which the patient is undergoing. So these are the MACE events. Like if it is having very less MACE events for that particular surgery, like less than 1%, it is considered as low risk surgery, and like high risk surgery. In low risk surgery, generally where we are not at all much dealing with the vascular part, and not much of hemodynamic shift is expected, like cataract surgery, breast surgeries, laparoscopic appendicectomy, and cholecystectomy. In those, we can very clearly give surgical clearance without having much of investigation. Sometimes even ECG is not needed. We directly give clearance for such surgeries. When patient is undergoing for a high risk surgery where the MACE event could be more than 5%, and these are especially obviously major vascular surgeries or liver transplant, extensive abdominal surgeries where lot of fluid shift, third space shift would be there, pulmonary and pulmonary transplant, any lobectomy, pneumonectomy, all these are considered where lot of fluid shift will happen as a high risk surgeries. And intermediate risk, we have basically renal transplant to remember, and then head and neck surgeries, and orthopedic surgeries, and neurological like TURP very commonly day to day we give clearance. So all these fall into the intermediate risk. So when we club together the patient's risk and the surgery under which the patient is going for, these two are clubbed together. If clubbing two together, like somebody with no clinical risk factors, as I mentioned previously 5, and patient is having cataract surgery, I need not to do even single ECG also, and I directly give clearance. If patient is likely like straightly going for any aortic aneurysmal surgery and very extensive oncologic abdominal surgery, then I know patient is at already very high risk from surgical point of view itself. And then if I see the clinical parameters also for MI, LV dysfunction, all these things, if it is falling into very high risk, then first I have to stabilize the patient first, if the condition allow from surgical point of view. So we have to stabilize the patient and then go for the surgery. And when it is falling into the moderate risk, clubbing together the clinical criteria of that particular patient and the surgery side, then we need to see what is the functional capacity of that particular patient in day-to-day life. Like somebody is not doing even less than 4 meds. 4 meds means he is not able to take take care of his own things, like can't take bath also, in like dressing, undressing also he needs support, can't walk on a like in 1 to 2 rooms inside his home also, like 500 meter to 1 kilometer at a level ground also it is very difficult. Then in such scenario we need to do some stress test to know the patient cardiac risk. Otherwise, if patient is able to do more than this activity, if they are able to walk 2 flight of stair, can go on a level ground up to 4 blocks, or if very like strenuous activity, somebody is doing gymming, somebody is doing swimming, playing football, then we need not to do all these stress tests straight away. Considering his physical activity, we can give the fitness for the surgery from cardiac point of view. So this is the club thing what I would like to explain. Like we have to see the clinical scenario of that particular patient regarding his cardiac, any vascular event history, diabetic status, and CKD status. And if none of this is there and patient is doing more than 4-minute activity, we need not go for any stress test and we can give the surgical clearance. Whereas we definitely look for the surgery if it is high risk surgery and patient is having 1 or 2 risk factors from clinical criteria, we should definitely do the stress MPI or dobutamine stress echo test. And if unstable patient, unstable in the sense like patient recently had MI in the past 2 months, underwent stenting, patient already having very class 3 or 4 angina or recent decompensated heart failure, then if surgery allows, we should wait for stabilization of such patient and then go for the surgery. So this is the like if when we do cardiac evaluation, the first test or the initial test is always the electrocardiography ECG. So if patient is not having any cardiac symptoms and he is or she is falling into the low risk surgery, then straight away we don't need ECG also, we can give clearance. If patient is falling into the going for any high risk surgery, as I mentioned previously, then definitely ECG has to be done if patient is not having even symptoms. Symptomatic patient always first step to take at least ECG, and intermediate risk we have to club always with the clinical risk scenario and then take a call for ECG. At least we will be always needing. It is very simple test, always everywhere available. So echocardiography routinely not needed for all the patient, and especially it should be done who have already cardiac risk factors of having LV dysfunction, not done in previous 6 months or 1 year, for rest echocardiography at least, or who had already CAD patient. All these patients have to be done. And those patients who are undergoing vascular surgery, very high risk surgery, in such scenario, echocardiography has to be done. Routine is not needed, like we are subjecting even for cataract surgery, get an echo and then we will give clearance. That should not happen. So we need to weigh how extensively we need to investigate a particular patient for a particular surgery. So if I say stress testing, so definitely imaging stress testing or dobutamine stress testing, both should be done in high risk surgeries where patient has more than 2 clinical risk factors and their functional status we don't know, where they are not almost having sedentary lifestyle. So in such scenario, we need to have, that is class 1 recommendation, but still it could be done whoever is having 1 or 2 clinical risk factors for increased MACE in perioperative period and going for intermediate or high risk surgeries. So nowadays we do biomarkers also, especially troponins, to know the myocardial injury status. So at that point we have to keep in mind troponins could be raised in non-cardiac scenario also, like sepsis, atrial fibrillation in CKD state. So patient going for specially vascular surgeries or also have 1 or 2 cardiac risk factors in the form of LV dysfunction or recent ACE with stenting in past 6 months. There we can have a baseline troponin level so that we can monitor post-operatively. If a patient, as I said, if they have MI also in peri-surgery, it's not the way, like they will have atypical presentation, they will not present with frank chest pain. Sometimes we need to, and patient is still on intubated and can't tell complaints also. So that scenario, we need to sometimes monitor with biomarkers as well. And for LV dysfunction patient, we monitor with the pre-BNP and pro-BNP levels. And these are important in LV dysfunction patient because they give a prognostication for managing such patient. So optimizing medication also helps. And if they are baseline very high before taking for any intermediate or high risk surgery, so we need to optimize medication so that these BNP levels falls down with optimization of medication, and then we consider the patient for surgery. CT angiography, we do know, knowing the calcium scoring in CT scan, it definitely correlates with the coronary atherosclerosis. But guidelines doesn't hold for this investigation for evaluating patient, especially where we need to, especially seeing for the stress management of that particular surgery. So it doesn't hold any role, CT angiography, so it should not be done. And coronary angiography, if needed, it will be needed like somebody is having very high risk from clinical profile, as well as a patient had a very high risk, some vascular surgery, sometimes like a carotid endarterectomy surgery, we are dealing with vasculature, and then patient is falling into high risk, or in perioperative period, patient has got acute coronary syndrome. In that scenario, we need to do coronary angiography. So when we talk about these investigations, we have done ECG, echocardiography, and stress evaluation wherever it was needed, and we have given our cardiac clearance. But we need to see whoever already been a cardiac patient in various manners, whether it is a valvular disease or LV dysfunction or CAD patient. They will be on the certain medications, and most commonly they will be having on beta blockers, ACE inhibitor, ARBs, statins. So whoever is on long-term chronic beta blocker therapy, we should continue the similar way in this perioperative period also. And wherever it was not started, and now we are evaluating patient, and we found that this patient is going for a high-risk surgery or intermediate risk surgery and falling into high risk group from clinical scenario also, that he can have MACE events in a higher side, then we start off with beta blockers before surgery as well. But here we need to take a point, like beta blockers needs titration. We can't suddenly give in high doses at the start. So at least 1 week before surgery we should start, and so that patient get tolerance to those beta blockers, and it is not a sudden change in hemodynamic status which hamper the perioperative period in way of like bradycardia or hypotension while undergoing for surgery. So similar way, statins already CAD patient, like diabetic patient who is on insulin, they would be on statins and sometimes on high dose. So the way they are taking statins, similar way it would be given, and it will not be taken out before surgery. The thing is, if we are starting, like we have risk stratified the patient, previously patient was not on statin, we have risk stratified, and we come out with a conclusion like this patient can have a high risk of MACE, and this could be high risk surgery, then we generally start with statin preoperatively also, so that we can reduce MACE events. But still, at least statin also doesn't act immediately. At least a 2-week coverage is needed before going for surgery, so that we can give some stabilization of these plaque ruptures if expected with MACE, more MACE events during this perioperative periods. Similar way, ACE inhibitor, ARBs, patient LV dysfunction, they have to take it, and it will be continued. Only thing is that on the day of surgery, we can interrupt them, because to prevent hypotension in that particular day, and it can be restarted once patient surgery is done and BP blood pressure levels are above 100. We can slowly again start ACE inhibitors in ARB such patients. The most important thing what we deal is like patient is post stenting and post PTA status, and they have called us for stopping these dual antiplatelet therapies totally, or they can go on one. All these issues are very common. So we, in such scenario, we have to see what is the thrombotic risk, and we have to weigh against the hemorrhagic risk in that particular patient. Like patient has a recent ACS, in the sense like 6 months back he had ST elevated MI, underwent stenting. So in that scenario, thrombotic risk would be more than if somebody has gone stenting for stable coronary artery disease. So now the guidelines, what they say, if patient just underwent balloon angioplasty for a particular vessel, then after 14 days, we can interrupt these dual antiplatelet therapy. And if patient has undergone bare metal stenting, then after 30 days, we can interrupt this dual antiplatelet therapy. And drug-eluting stent, when 2014 guideline came, they told for strictly 1 year only. It cannot be interrupted before that. But newer generation stents and a lot of studies now has come, which says with newer technologies we can stop dual antiplatelet therapy after 3 months. And some recently 4th generation stent are telling just for 1 month also. But still guidelines says like at least 6 months you need to give dual antiplatelet therapy for drug-eluting stents to go before surgery, if that surgery could wait. Then aspirin, the other point is that interrupting P2 vital inhibitor is one thing, and that we need to stop aspirin also to be weighed against the surgery patient is undergoing. Like if patient is undergoing a major vascular surgery, definitely aspirin also has to be withheld. And we need to know that if patient have a thrombotic event and stent thrombosis in this perioperative period, then mortality is very high, almost 4 times than in routine what we see in stent thrombosis. These are the certain different criterias what we see when we are going to stop dual antiplatelet therapy for particular patient. If we see the stent fractures, then we need to see whether it is a bare metal stent or drug-eluting, whether it is a very long stent that is more than 20 millimeter. In patient risk factors, we have to see patient is having LV dysfunction, and CKD as well as anemia is also there. That also makes him high risk for having more of stent thrombosis chances. And in surgery, we have to see like patient is whether going to have high bleeding risk or high prothrombotic. All these factors should be balanced before interrupting the dual antiplatelet therapy and stopping aspirin. So if we see that like patient had a major MI just 2 months back only, recently stenting has been done, then we need to give some bridging therapy. We can stop major vascular surgery is going on, that is to be done like some dissection or so. In aortic dissection, we have to withhold both, and we sometimes need to bridge with the tirofiban or aptifibatide, the GP2B3A inhibitor, or cangrelor, IV cangrelor, very short acting. But the problem is cangrelor still not available in India. We have to manage with tirofiban, aptifibatide. These are short acting. We can withhold, we can bridge when we are stopping P2 oral before 3 days, and then bridge this with the infusion of tirofiban or aptifibatide and restart as the hemostasis achieved after surgery. So there are no different if patient get ACS in the form of whether non-ST elevated or STMI. It should be managed the way we manage routinely ACS patients. Angiography has to be done, and patient whatever management is requiring, we need to do. Sometimes like surgery is very urgent, we can't wait. In that scenario, we can come out with balloon angioplasty so that we can stop dual antiplatelet after 14 days of surgery, as I mentioned before. In LV dysfunction patient, we are more worried because it affects the post-operative cardiac event rate. So LV dysfunction patient should be on AC inhibitor, should have beta blockers, and how we are going to titrate all these factors we need to see. So valvular heart disease, I told left-sided, like stenotic lesions are worse than regurgitant lesions, and in that also aortic stenosis and mitral stenosis more than moderate is always fall into the high risk. We need to balance like if somebody is having severe aortic stenosis symptomatic, definitely we have to treat aortic stenosis with aortic valve replacement, or if patient is too high risk for surgical point of view, then to consider TAVI or balloon aortic valvuloplasty. We have to balance all these things. In mitral stenosis also, if it is more than moderate mitral stenosis and patient hemodynamic things are not like stable, patient is already having atrial fibrillation, so very high risk of MACE events perioperative, so better to do balloon mitral valvotomy before taking for any intermediate or high risk surgery. So as I said, pulmonary hypertension itself is a makes surgical perioperative period high risk. And as I said, targeted pulmonary hypertension therapies need to be continued during that period, and we need to take pulmonary hypertension special teams who treat with this. That team should be contacted and should be taken, like whether perioperative period patient to be shifted on like inhalational or IV prostacyclins, or targeted therapies has to be intensified. Sometimes patient, as I said, atrial fibrillation, very frequently old age patient undergoing surgery, and they will be on warfarin oral vitamin K antagonist and then Novax. So all these has to be properly interrupted in time, and wherever high risk, we need to bridge with the low molecular weight heparin or plain heparin infusion depending on the scenario, and to resume this so that we can prevent the stroke event rate during that perioperative period in AF patients. Anticoagulation management, I told, like patient on mechanical prosthetic valves. There, if patient is mechanical mitral valve, then it has to be braced always with low molecular and unfractionated heparin. But if it is a mechanical aortic valve and just patient not having other risk factors like AFib or LV dysfunction, so sometimes we can skip in aortic valve with normal LV from bridging, and to restart after surgery as early as possible, anticoagulation oral. Patients sometimes are on device therapies like pacemaker or ICDs. In that scenario, when surgery is being done, these cauteries can hinder, especially the monopolar cauteries can hinder with the programming. In that scenario, we need to see the devices so that we can cannot have the change in parameters of devices, or some ATP function is not hindered, or in pacemaker is not inhibited due to oversensing. All these things should be managed. So a simple stepwise approach to pre-operative assessment and peri-operative management includes the acknowledgement of those surgical urgencies, exclusion of acute unstable conditions, special consideration of patient with coronary stent, dichotomous risk stratification, and estimate of functional capacity. All these when clubbed together, then we are able to manage these patients successfully in their perioperative manner so that they go home happy and safely. Thank you so much for patience hearing.
Thank you, Dr. Rajni, for nice deliberation. If there is any questions, do you like to ask? Mr. Sanjay will ask a question.
Sure, sir.
Dr. Raju, nice presentation. I have a question about patients who are on ACE inhibitors and they come for the cardiac clearance for you. So, do you advise them withholding this ACE inhibitor before they go for non-cardiac surgery under GA?
Sir, I need to see the scenario, like if patient is taking ACE inhibitor for hypertension, and need to see what is his target BP at that time. If he is able to maintain his target BP with those ACE inhibitor, we may not take out. But if his BP is towards lower side, like I'm seeing his blood pressure at 110, and patient is going for intermediate or high risk surgery, or especially some extensive abdominal surgery, whether it is oncosurgery or especially vascular surgery, then I would like to stop on the day of the surgery. It need not to be stopped like 2-3 days before. That day can be skipped, and when patient like managed operatively properly, then we can see as his BP comes up post surgery, then we can add on next day, or can take a gap of 1 or 2 days later. We need to balance both, like what is the demand, like if patient is managing getting ACE inhibitor for LV dysfunction. So if a patient is like having the 20-25% ejection fraction, his BP we are giving for this target for ACE inhibitor is for LV dysfunction, for preventing the scarring and fibrosis of the LV myocardium. So in that scenario, we can withhold it, so that because in such patient BP may not be very high, they would be borderline BP 100-110. In that scenario, we can skip in perioperative period for these ACE inhibitors and ARBs.
This is in context with your blood pressure scenario. But
Yes, clinical. We have to always see, sir, while giving these fitnesses, we have to see for what particular disease patient itself is already having in risk scenario. Function, CAD, those, and then we need to combine it with the kind of surgery patient is undergoing, and then we need to club this and see what is the functional status of that particular patient. All three taken into account, and then we decide what investigation we should see, so that we can manage its perioperative risk and reduce the perioperative risk of MACE events, and patient comes out from surgery smoothly.
So no, I just want to share my experience with these kind of patients. Because we do heart surgery. So when they on cardiopulmonary bypass, and these patients, if they, not all of them, but some of them, we have found that they become extremely vasoplesic, and they use a lot of pressures while coming off bypass, and they remain, lactic acidotic and for a long time, and they take time to rewarm, and we have difficulty coming off bypass. Some of them are so bad that you may even consider giving methylene blue for these patients because they're so vasoplesic. So this is not
yes, sir.
commonly, but in few cases we find, and that's why our practice is normally for cardiac surgery patient who undergo CP bypass. So then that patient we withhold it for a couple of days unless there is a reason not to do so.
Yes, sir. True, sir. You are very true. Wherever we are seeing that, like a lot of fluid shift is there, third stage fluid shift, and we are going to hinder the vasculature. Patient is going to be on pump. All these scenario, we have to stop it.
Thank you, Dr. Rajni. Now for the next.
Thank you.
Now I am inviting Professor Sanjay Kumar, Dr. Vivek Raj for the presentation, and first presentation is Dr. Pravesh Vishwakarma. He is Professor of Cardiology from Nari Cardiology Center, King George Medical University, Lucknow. He has more than 80 publications in peer-reviewed and index journal, and participated in several trials. Now, the topic of discussion is STEMI in 2021 with real-life cases. I will request Dr. Pravesh to be precise, and as we are running short of time, so if we'll try to finish as early as possible. Over to Dr. Pravesh.
A very good afternoon. I guess I'm audible. Am I audible?
You are audible. You are audible.
Thank you. Thank you to the organizing committee for inviting me or giving me this opportunity to present the topic. So I'll be speaking about management of STEMI in 2021. We know that the incidence of STEMI has fallen over the last decade, but somehow the 1-year mortality rate continues to be around 10%. So instead of giving a whole review, I'll talk about these 5 topics. The issues which are really pertinent to our day-to-day practice. For example, primary PCI versus pharmacoinvasive, role of thrombus aspiration, deferred stenting, multivessel disease, and late presenters. So as we are already running behind by 2 hours, I will request Dr. Alok, if anywhere I go overboard, you can stop me at any point. So before I continue with my first talk, that is the primary PCI versus pharmacoinvasive approach. The data behind the evidence behind the primary PCI has been backed by a large number of clinical trials as well as meta-analysis. As you can see from this meta-analysis of 8,000 patients, it not only improves the patency rate and reduces the bleeding rate as compared to thrombolysis, it also improves the mortality and reduces the chances of non-fatal MI, cardiogenic shock, and heart failure. But in an ideal scenario, you would advise primary PCI for all the patients, but world is not ideal because we are limited by number of centers which provide primary PCI facilities. There may be even lesser number of centers which provide round-the-clock primary PCI facilities. There is usually a lack of awareness by patient as well as some primary contact physicians. They don't refer the patient for primary PCI. Most of the times, the essential time is wasted in counseling and medical management. Once the patient is even if the patient is counseled and is willing, there may be certain financial constraints. And last 1.5 years, we have been dealing with the COVID pandemic, which adds additional impediment to the prompt care. And there is some concern for healthcare personal safety as well. So this is the usual chart for pharmacoinvasive approach, which is an alternative to primary PCI. So if the patient approaches you within 2 hours of his symptom onset, thrombolysis appears to be good choice. But beyond 2 hours, if you can provide the a primary PCI facility within 120 minutes of first medical contact, primary PCI should be the choice. If this cannot be done, pharmacoinvasive approach should be done, because you can thrombolize, you can offer the streptokinase, tenecteplase or alteplase within 10 minutes to the patient. And let's see the evidence behind this pharmacoinvasive approach. I'll start with the transfer MI. This was the trial actually which showed that after fibrinolysis, it is feasible to have the patient transferred to another PCI capable center. It was not only feasible, but also it was an effective methodology to reduce the incidence of death and MIs as compared to fibrinolysis alone. The largest evidence which vouches for the pharmacoinvasive approach is STREAM trial. It was recently published in 2010. Here, patients were equally patients who could not be offered primary PCI within 2 hours. They were equally divided into 2 groups. One group underwent pharmacoinvasive approach. Another group underwent primary PCI group approach. So what we can see is the pharmacoinvasive approach. The patients who received fibrinolysis first, the composite of primary endpoint was more or less similar in both the groups. It was similar to primary PCI. And if you look at the individual endpoints, all-cause death, cardiac deaths, congestive heart failure, cardiogenic shock or reinfarction, all the endpoints were more or less similar in both the groups. Though there was some concern for increased intracranial hemorrhage, the protocol was amended midway, and half dose of tenecteplase was given to patients who were above the age of 75 years. After this amendment, if you compare, the bleeding rate was compensated, and it was not significantly higher in the thrombolysis group. There is another study, STEP AMI. It is an Indian study, an observational randomized controlled randomized study where the 2 groups were compared, primary PCI as well as tenecteplase followed by PCI group. So if you can see, though the primary PCI was better as compared to the pharmacoinvasive approach, but the pharmacoinvasive approach appears to be a suitable alternative to patients, especially if they are less than 75 years of age. So in summary, if primary PCI can be offered to the patient, and if it can be done within 2 hours of first medical contact, it remains gold standard. There is no doubt about this, but there are certain situations where pharmacoinvasive will be a better choice because it is affordable, it is widely available, and it is easily acceptable to patient. If you ask a patient to arrange for a large amount of money, he can't do it within 30 minutes or 2 hours. So you thrombolize the patient with whatever you have, and then subject the patient to PCI, you counsel him, he gets ready within next 24 hours. Pharmacoinvasive approach has compressible results in terms of CV endpoints, but remember, the trials which show this kind of data, they utilized tenecteplase and alteplase, not the streptokinase and urokinase, which we are usually using in our practice. So effort should be that we switch to these molecules, tenecteplase and alteplase, the fibrin-specific molecules for fibrinolysis. Though there is some concern for increased bleeding, which is especially seen in elderly, so modified dose of thrombolytics can be used in patients who are above the age of 75 years. Coming to the second topic, that is the thrombus aspiration. As you can see from the image which I am running, this is a patient, this is a real patient who came to us for primary PCI, 60-year-old diabetic male, inferior wall MI, came to us within 8 hours. We wired it, and when we dilate it, what you can see is there is a large chunk of thrombus which is gradually migrating to the distal circulation and completely occluding the PDA. So what would you do? Would you just leave it as such? You will give some GP2B3 inhibitors, or you will do a thrombus aspiration. Let us have a look at the guideline recommendations for thrombus aspiration in primary PCI patients. Gradually, over the period of time, earlier it was class 2A indication, but gradually as newer data has appeared, now thrombus aspiration, routine thrombus aspiration in primary PCI has not recommended. It's a class 3 indication, but they say that you can use a thrombus aspiration as a bailout strategy but there is no data to suggest this recommendation. It is a class 2B indication. So let's have a look at the RCTs of the thrombus aspiration. The first randomized control trial, which was a single center trial, TAPAS. It was a marvelous trial. It showed promising results. There was a better flow and myocardial blush. But also at 1 year follow-up, there was a reduction in MIs and death. But this was a single center. The larger scale trials like TASTE and TOTAL refuted the evidence of TAPAS, and they showed that there is no reduction in mortality. In fact, there is some increased risk of stroke. There is some association of increased stroke. This may be because of some thrombus getting migrated out of the catheter, or increased platelet aggregation, or increased platelet activation induced by the mechanical and the suction capability of these thrombus catheters. If you look at the meta-analysis, again, these are large-scale meta-analysis combining all kind of patients, up to 20,000 patients. All of them actually failed to show any kind of significant reduction in mortality or infarction or TVR. In fact, there was some increase in TVR. So all this leading to the fact that routine thrombosuction for all primary PCI should not be done. That means you don't, whenever you are doing a primary PCI, you don't start with your thrombus aspiration catheter. You have to be choosy. For example, so you cannot completely avoid thrombosuction. So if you look at these linear thrombosis, the filling defects, large thrombosis, obviously you will have to adopt to some kind of strategy to reduce the thrombus burden. And these are the real life thrombosis. You can see the large serpiginous linear thrombosis. If you aspirate them, you can be happy that the result was better. Or you can utilize thrombus aspiration as a bailout strategy. Here, one patient presented with an ostial occlusion of LAD while doing balloon dilatation after wiring. You can see one thrombus migrating to and occluding the OM. Patient started having severe pain. Immediate wiring was done, and you have no other choice but to have a thrombus aspiration of this OM. And final result, you can see a successful PCI of LAD and a successful TB3 flow in the OM. Patient's pain improved and patient was saved. But while doing, because there is no advantage of mortality benefit with thrombus aspiration, you have to be really careful while doing it. Suction should be on before you have approached the thrombus. You don't start when your tip reaches the thrombus. You have to start the suction well before the thrombus, and suction should be off when your tip is out of the Y connector. Slow packing movements and forward movements should be done at the thrombus, and guide should always be engaged while withdrawing the catheter so that there is no risk of additional stroke, and liberal back bleed to eliminate whatever thrombus you have left inside the guiding catheter and whatever air has been sucked because of an active suction by the thrombus aspiration catheter. So in summary, you can't be at one of the extremes, like no thrombus aspiration for at any time or thrombus aspiration for all. Somewhere you have to be between. You have to have a rational approach. It provides a better TB flow, but it is not a guarantee of better blush or improved CV outcomes. But it does give you a better final angiographic result, especially if you have got a high thrombus burden. You can go and sleep peacefully with satisfaction that you did a fine job with the patient. Now coming to the next issue, that is the multivessel disease in STEMI. This is a patient who's a smoker, elderly, has a history of PCI to RC in the past, now presented with anterior wall MI. You can see there is a TB2 flow in LAD. There is a diagonal disease at the ostium, OM is CTO, and RCA, there is an ISR of 70%. So what we do, obviously, because there is a TB flow, you are going for here we adopted a pharmacoinvasive approach. Patient is hemodynamically stable. You are going to do the PCI of LAD. What about the PCI of diagonal? What about the PCI of OM and RCA? Would you do it at the same sitting before discharge or later on, or you would just be happy with the primary PCI, PCI of the LAD? So let us have a look. So multivessel disease is not a very uncommon scenario. At least half of the STEMI patients will have multivessel coronary artery disease. If you only do culprit only vessel, that means if you do PCI to LAD only, it will be a short procedure with lesser complications, lesser cost, and a satisfied customer that you did a cheap job and a good job. But what about if you adopt to a complete revascularization? Obviously, increased number of stents, increased cost, increased procedural time, and with the increased number of stents, you expect increased number of complications. And not less than that, you also run a risk of being frowned upon by your peers as an irrational implanter. So let us have a look at the data behind the multi-vessel PCI. PRAMI and CivilPrit were the trials which show significant reduction in composite endpoints of mortality, non-fatal MIs, and refractory angina. It was predominantly driven by reduction in number of unplanned revascularizations rather than the reduction in death or MIs. Coming to the largest trial, which is the complete trial, it included approximately 4,000 patients, and they compared complete revascularization versus culprit lesion only PCI. If we look at the data, the first composite primary endpoint, which was a composite of death or MI, there was significant reduction in mortality as well as MI. And the second primary outcome, there was an even greater reduction in the ischemia-driven PCI. That means this is the first of complete ischemia.
Your slides.
Pardon?
You can summarize your slides now.
Okay. So we can see that there was a reduction in mortality as well. This was now coming to Flower was one of the Dynamic 3 primality was showed that while choosing which vessels to do, you can adopt to FFR guided. This strategy was also successful and reduced the number of ischemia-driven revascularizations. Flower MI compared whether angiographic decision or FFR guided PCI is better. Both these strategies are better. So there is a meta-analysis which compared whether this multi-vessel PCI should be done in the same setting or stage. Both the strategies are equally well. There is no heterogeneity. You can do it at the same time of primary PCI or before the discharge. So is it valid for pharmacoinvasive approach in our Indian setting? This is a subgroup analysis from the complete trial. It showed that this strategy is equally effective in both whether primary PCI or pharmacoinvasive approach. So in summary, so if you adopt to complete revascularization, try to do it before discharge. Patient is happier. There is no angina on follow-up. Apart from complete trial, none of the other trials have shown any reduction in terms of death or MI. But if you are somebody who prefers to do culprit only, you will always have an opportunity to evaluate the ischemia on follow-up, probably by non-invasive means. But this strategy has never been tested. So what about if the patient is in shock? The recent guidelines after the culprit short trial show that if you do this multi-vessel PCI in a patient with shock, you'll end up with increase in mortality and increase in renal replacement therapies. So in patients with shock, only culprit vessel PCI should be done. Defer stenting, I'll just skip this. There was a trial which is the defer STEMI. It showed the better angiographic results and smaller infarct size at 6 months by CMR. But Dynamic 3 defer, it failed to show any improvement in the clinical endpoints, that is the MACE. And also there was a high risk of unplanned TBR because the vessel got occluded after 48 to 72 hours. Meta-analysis also shows that the angiographic results are better, but there is no improvement in mortality. By having a better angiographic results, you can reduce the thrombus burden, less chances of slow flow, no flow. You can also reduce the number of stent sizes. And also you can skip altogether the PCI, the stenting. I'll just skip. So late presenters, I think I'm way above my time, so I'll stop here. Just in the end, pharmacoinvasive is a comparable alternative, especially in low middle income countries like us. And thrombus aspiration, not for all, but it does help some of the patients. Defer stenting is a better angiographic results only for stable and patients who have got TIMI3 flow. If the TIMI3 flow is poor, you have to go for some kind of minimal intervention so that the flow improves. Complete revascularization is better. It reduces the ischemia-driven revascularization, if possible, should be done before the hospital discharge. And latecomers, because I skipped this, so I'll stop here. Thank you very much.
Thank you, Dr. Pravesh, for a very nice presentation. Any question from audience?
If there's no question from anyone, I have one question from Dr. Pravesh. This is about his, what is your approach for primary PCI in the patients? Are you go by the culprit vessel, or you go by, you target to do a complete PCI, and how often do you do it FFR guided PCI?
So earlier I was very fond of culprit lesion only PCI. Most of the times, whether it is a non-ST elevation MI or primary PCI or pharmacoinvasive approach, I used to do culprit lesion only at that time, and at a later stage, I would evaluate the patient's symptoms and then offer him the additional PCIs if it was needed. But after COVID became here, there was always a issue. Most of the patients, they always have to come for screening appointments and additional COVID investigations. And most of the times their angina persisted despite culprit vessel plastics. So then we adopted to this complete revascularization because it was guided by a large number of trials. Now personally I favor complete revascularization in stable patients if it can be done. If patient tolerates the culprit vessel PCI easily, there is no complications in the procedure, I proceed with the complete revascularization, but only of those vessels which are above 90% lesion. So angiographic criteria is my default. FFR guided very rarely because we have a lot of patient rush. So sometimes, despite even if you want to do an FFR, it becomes really difficult in a hectic cath lab. So angiographic and only those lesions which are above 90 or if there is a poor TIMI flow.
Thank you.
Next speaker is Dr. Akhil Sharma. He is Professor, Department of Cardiology, KGMU, Lucknow. He is International Fellow of SKY, International Associate Member of SAC, International Associate Member of ESC. And his area of interest is complex coronary intervention, structural heart intervention, pediatric interventional cardiology. He has various publications, total 33 publications in various international index journal, national journal, and he is also author of 2 book chapters. He is principal investigator of tenecteplase hetero study, and he is co-PI heritage study, horizon study. So I will invite Dr. Akhil Sharma to speak on how to approach unstable angina and NSTEMI in 2020.
Thank you. Good evening, everyone, and I heartily thank Dr. Alok to arranging this kind of the academic meeting in this hard time. And I just start my presentation without wasting any time. Is my presentation visible to all of you?
Yes, it is visible.
Yeah, thank you. So today my topic is how to approach patient of NSTMI unstable angina in 2021. I will start my presentation with the 3 case studies. This one is the first patient is 55-year-old hypertensive male who has the angina from last 6 months with recurrent episode of the rest pain, presented with the syncope, and now again presented with the ACS with chest pain and diagnosed as the ACS NSTMI. ECG suggestive of the generalized STT change, troponin positive, but echo is normal. And we did this angiogram of the patient, and the angiogram shown only the milder disease with the generalized slow flow in all coronary artery disease. And proximal RC has minimal disease. So this is the typical case of the Minoka, but presentation seems that the patient has a severe coronary artery disease because syncope with recurrent ACS on the medical management. And second case is the 65-year-old diabetic patient, asymptomatic 7 days before when he developed the chest pain during the cycling, and now presented with angina on effort. ECG is normal, troponin normal, LVEF normal, and we did the angiogram. And angiogram shows the severe taper vessel disease, and the patient sent to the coronary artery bypass for revascularization. So, and third case is a very interesting case, 48-year non-diabetic, non-hypertensive patient presented with off and on chest pain from 2 days, now presented with the palpitation from 2 hours. ECG shown that ventricular tachycardia with self-reverted. and reverted ECG shown STT changes, global LV hypokinesia on echocardiography, troponin positive. This was the ECG, shows the generalized STT changes. And when we did the angiogram, patient had the complete occlusion of the left main. So this case study just give to idea that the patient of the STMI have a particular hemodynamic or clinical profile. But when we come to the patient of ACS and STMI, they are the broad spectrum of presentation, and they have very minimal risk of MACE to very high risk of the MACE. So we have to evaluate these patients systematically and have to manage accordingly. To manage these patients systematically, we start with the further steps like the initial evaluation and diagnostic pathway follow. Even after stabilizing of the diagnosis, we have to assess the risk of the future event, choose the antithrombotic treatment, choose the invasive or non-invasive, routinely invasive or selectively invasive, and revascularization by the PCI or the CABG, and discharge care and post-discharge care to reduce the further event. My presentation mainly depend on the 2020 ESC guideline and 2021 ACC AHA guideline for chest pain management. And ESC did one thing that they changed the name of NSTMI to NST-ACS. And by the definition, we all know that the NSTMI has the broad spectrum of presentation. Patient can be presented from the cardiac arrest to electrical instability to asymptomatic patient. Usually chest pain, burning or tightness is the prime symptoms, and patient can be divided according to ECG in ACA, STMI, NSTMI, and unstable angina. When we come to the epidemiology of NSTMI patient, 1995 to 2015, in over the 20-year, NSTMI patient in ACS survey increased from 1/3 to more than half. The angiography in first 72 hours increased from 9% to 60%, and PCI increased from 12.5% to 67%, and the increment in the proper diagnosis management by the revascularization or the potent antiplatelet and statins, the 6-month mortality decreased from 17.2 to 6.3. So we have to meticulous and we have to systematic to arrange these patient the diagnosis. We have to evaluate our patient in emergency as a whole. We have to evaluate their symptoms, vitals, ECG, troponin, different biomarkers, and according to this we can divide patient into admission to CCU, ward, observation, or discharge. If we can't able to decide here, we can help take the help of the non-invasive imaging for the kind of patient. So in this slide, it's a very informative slide when we evaluate patient from the population who presented as a suspected MI. If patient is has the persistent ST elevation, patient has the cardiogenic shock, or patient had cardiac arrest, they directly rule in and admitted in the ICU and managed accordingly. If the patient didn't have all these kind of thing, ECG shows some changes, we should have the high sensitivity troponin whenever patient contact us, and try to get the result within the 60 minutes of the sampling of patient. And if the HS troponin T level is shown the rise in the troponin level, directly patient rule in and admitted in the ICU and manage accordingly. If the level is normal or below the upper normal limit and chest pain onset is more than 3 hours, we can rule out the patient from ACS category. If the result of our test is not conclusive, we can go for the second test of HS troponin T, and after 1 hour, and result if the troponin positive, admit patient and manage accordingly. If it's negative, rule out the patient. Even second test of HS troponin, if we could not able to conclude diagnosis of ACS, and there is a high chances of or high clinical suspicion of ACS, we could have the help of the echocardiography to rule out the renal valve motion abnormality or know the LVEF of the patient. And we can go for the third sample at the 3 hour of the HS troponin T. If it's positive, again rule in. If it's negative, then observe the patient and to rule out the other possible diagnosis which lead to the troponin changes. And categorization of patient according to rule in and rule out strategy, we can identify patient who rule out is very low risk for MACE at 30 days is less than 1%. And if patient categorized as the high risk, they have the MACE rate at 30 days is more than 70%. So we have to rule out the patient accordingly. And one more thing which changed the management of the NSTMI patient is the high sensitivity troponin assay. When troponin level of patient is more than 100, the conventional and high sensitivity troponin did same function, and there is no added advantage of HS troponin T. But the HS troponin T assay help us patient in the gray zone where the conventional assay could not identify this patient, and this is the patient population which can be diagnosed as a ACS NSTMI who could not be identified by the conventional assay or diagnosed as the unstable angina. This is the slide in which whenever troponin rise, it's not always the ACS. We all well known in the COVID pandemic when the troponin is hugely rise. So these are the number of causes of the troponin rise. Whenever we have the patient of troponin rise with the doubt in diagnosis of ACS, have to rule out all other possible causes. And what the clinical implication of high sensitivity troponin, it have definitely very high, almost 99% negative predictive value. Troponin HS troponin T assay decrease the troponin blind time, and we can identify patient of ACS early, so we can admit patient or discharge or decrease the emergency department workload for the patient. As I earlier mentioned that the HS troponin T absolutely increased 4% diagnosis of the type 1 MI and relatively 20% of the diagnosis of MI, and reduce the diagnosis of unstable angina because the patient diagnosed as the NSTMI. Simultaneously, twofold increase in the type 2 MI diagnosis with the help of the HS troponin T assay. When HS troponin T level increase is directly proportional to cardiomyocyte damage. So whenever the level increase, it's increase the likelihood of the MI and simultaneous prognosis worsen for the patient. If level is more than 5-fold of the upper limit, 90% predictive positive value for the type 1 MI. If it's 3 times high, then the positive predictive value is 50 to 60%. So as I earlier mentioned that the whole evaluation of the patient with the clinical history, symptom, ECG, vitals, and troponin is class 1 indication, and we should follow the 1 hour or 2 hour for rule in and rule out strategy. If it's not possible, then we can go for the 3 hour possible strategy. And for diagnostic purpose, ESC 2021 rule out other biomarker. There is no need to no need for evaluation of the CPKMB copeptin for the diagnosis of NSTMI. They are the class 3 indication. Imaging, we have to have ECG within 10 minutes of the contact. We can took the help of the echocardiography to assess the global LV function or rule out the other diagnosis. We can choose the CT angiography in place of the invasive coronary angiography in patient who has the low to intermediate likelihood of CAD with the normal ECG or inconclusive ECG or troponin T. All patients of the NSTMI should be monitored in the ICU or high dependency unit at least for 24 hours or whenever the patient get the PCI. If patient has a higher risk of arrhythmia, prolonged monitoring should be advised. When patient admitted, we have to identify the risk assessment of patient, for which HS troponin T is the most important criteria. After this, we can have the BNP or anti-pro-BNP level and other biomarker also excluded from the as a estimation of the NSTMI prognosis. And score for the risk stratification, class 2A indication for the GRACE score, which earlier class 1 for the 2015 guideline. And 2020 guideline also mentioned that we have to be more objective to assess our patient. We should not go by the individual discussion and decision. So we should use maximum score for the risk stratification, for the bleeding risk, for the ischemic risk. So follow the risk score for bleeding as well as ischemic risk or as well as the prognosis. So this is the Grace score slide. We all know that the Grace score include the CLIP class, systolic blood pressure, heart rate, age, creatinine level, cardiac arrest as admission, ST segment deviation, elevated cardiac enzyme, and all score calculated, and then the total score is less than 60. The in-hospital mortality is less than 0.2. If it's more than 140 is about 3%, and if more than 250 is about more than 50%. An academic research consortium for the high bleeding risk patient. If patient has the one major or two minor criteria, they classify as the high bleeding risk group of the patient, and the management of antithrombotic choice changes accordingly. I will discuss in next slide. And this is the risk score for the high ischemic risk when patient has the complicated CAD, and one of the criteria they decided as the high risk thrombotic class. And if there is only non-complex CAD and at least one criteria, following criteria, they decided as the moderate high risk of the calculation. And technical aspect like the 3 stent use, 3 vaginal lesion treated, more than 60 mm of the length, bifurcation or CTO, left main disease, then they all included in the complex CAD with the high ischemic risk. So now when we diagnose the patient, we prognosticate the patient. Now treatment start. We start the treatment with the antithrombotic and other drugs to prevent the future event and heart failure. So antithrombotic strategy should be decided started with the loading dose of the aspirin 150 to 300 milligram with the P2 by 12 inhibitor, which may be prasugrel, prekagrel, or clopidogrel. In 2000, according to ISAR React, they prefer the prasugrel over the ticagrelor for the NSTMI patient who receive PCI. Cangrelol or GP2B3 inhibitor is recommended for the class 2B indication in P2x2 NAPE patient. Unfractionated heparin definitely class 1 indication, but bivalirudin and enoxaparin downgraded 2A and 2B in this guideline. So the antithrombotic treatment should be decided according to the ischemic and bleeding risk of the patient, which can be governed by the patient characteristic like the age, sex, race, clinical presentation of patient comorbidities, or the OSC use and revascularization done with the PCI or CABG. So whenever we have the patient of ACS and STMI who receive PCI, unfractionated heparin class 1 indication, we have to assess the bleeding risk, and whatever the bleeding risk we decide to antiplatelet therapy and the duration of the therapy. So patient with the low bleeding risk should give aspirin with prasugrel, aspirin with precagrel, or aspirin with clopidogrel, any of the combination up to the 12 months. And after that, we can follow the patient with aspirin or rivaroxaban 2.5 mg BD for more than 12 after the 12 months if patient has the higher ischemic risk. And simultaneously, if higher ischemic risk is present, we can choose the aspirin with ticagrelor or aspirin with prasugrel or clopidogrel for another 12 months. If another strategy to low risk patient is the aspirin with ticagrelor for the 3 months. After that, the ticagrelor only for next 16 to 24 months. If patient has the high bleeding risk, then aspirin with clopidogrel for 3 months. After that, the aspirin only. And if patient has very high risk, then aspirin and clopidogrel, and followed by the clopidogrel only for rest 6 to 18 months. If patient had received the PCI with for ACS and STMI with AF, Dr. Pradhan in morning session elaborated this quite. I am skipping. We should go for the triple antiplatelet, triple antithrombotic therapy for 1 week. After that, dual antiplatelet therapy for with the single antiplatelet therapy, and the anticoagulant, oral anticoagulant for the 12 months. After that, only anticoagulant, no antiplatelet therapy. In patient with the high bleeding risk, the 7 days of the triple therapy. After that, the double therapy for 6 months, and after that, the OSC only. And if the patient has the high risk, then we should go for the triple therapy for 1 month, and after that, the double therapy for next 11 months, and after that, the OSC alone. As I earlier discussed, the prolongation therapy in patient who has the higher ischemic risk and short duration of the dual antiplatelet who has the higher bleeding risk, I already discussed. This is the busy slide, and it's discussed early in morning with Dr. Pradhan. But 2 points I want to highlight that any patient who has the higher bleeding risk, we should go for the angiogram as soon as possible to decide which category of patient and how we can manage patient by the medical PCI or CABG, as generally happen in the patient practice, should not delay our decision to go for the angiogram in patient who have the high bleeding risk. And the prasugrel and ticagrelor should not be included in the triple antithrombotic treatment. Now the revascularization mode and invasive or selective invasive. Whenever patient has a very high risk, they should go for immediate invasive therapy, and is the patient has the high risk, then go for the early invasive therapy for revascularization in first 24 hours. And decision of the PCI of CABG decided as earlier guideline. It's nothing new in this. So whenever we choose with the invasive, routine invasive or selective invasive, multiple trial done and the several meta-analysis, they conclude that the routine invasive strategy did not decrease all-cause mortality in all comer population. They increase periprocedural MI or bleeding, and in high-risk patient, they decrease the endpoint. But we have to remember that this trial done in the prior area where the radial access used minimally, the DAS not in the third generation DAS are not available, and the recent antiplatelet therapy, statins, or the upgrade happen. So when we decided the routine or invasive therapy, and now to decide the timing of it's less than 2 hours, less than 24 hours, or selective invasive even the after the follow-up. So whenever patient present to us and diagnosed as the ACS and STMI, if patient on the PCI center, then very high risk patient should go for the immediate invasive coronary angiogram and revascularization according to the very high risk criteria. Very high risk patient classified patient who has the hemodynamic instability, cardiogenic shock, recurrent refractory chest pain, life-threatening arrhythmias, mechanical complication, heart failure, and gross STT depression. And if patient has the high risk, then go for the invasive coronary angiogram in less than 24 hours. They are the patient who has the NSTMI, dynamic STT change and cardiac arrest at the time of the presentation, and Grace score more than 40. Technical aspect, radial access always preferred implant DAS for all patients. Complete revascularization, if possible, should done in the index hospitalization, and only culprit RT done in the cardiogenic shock patient. In patient who has the heart failure, emergency coronary angiography is recommended as a class 1 with the revascularization by the PCI or CABG, whatever the possible. IAFP routinely should not be indicated in kind of the patient. What new in the ESC guideline with the running short in the time, I'm skipping that because we know that the 0 to 1 hour algorithm is the new and is recommended as a class 1 indication. Pro-BNP and anti-pro-BNP included as the class 2A indication for risk stratification. Prasugrel 2A as the prefer over the ticagrelor. These are some changes which I already mentioned. And last stage is the discharge patient, and we should discharge, and at the time of discharge we have to plan to manage post discharge care. Lipid lowering therapy should be given. If we could not able to achieve our target, azithromycin or PCSK9 should be added, and blood pressure and diabetic control should be achieved timely. In summary, I just want to say that the NSTMI ACS has a wide range of clinical presentation as well as the risk profile. So there is no one rule for the management of this patient. HS troponin T improve prognosis, decrease troponin blind window. So we can have to identify patients soon in our emergency and can dispose of according to the value of HS troponin T. Early rule in and rule out strategy should be followed according to the local preference. If we have the HS troponin to assay, we should follow 0 to 1 hour or 0 to 2 hour, whatever is convenient to our local practices. One size does not fit to all, so tailor-made approach should be adopted for each and every patient with the view of the comorbidities, risk profile, and the coronary anatomy and presentation of patient. Use of risk score for prognosis, bleeding risk, and ischemic risk must be prompted and adopted to identify the high-risk patient and manage individually. Thank you. Thank you very much for your attention.
Thank you so much, Dr. Akhil. So,
I think I'm within time.
yeah, you're well within time. And I have one question for you.
Yeah, sure.
You mentioned about for the diagnostic modality use of highly selective troponin T. So the one we normally ask for, they're not highly sensitive?
It's actually is depend which HS troponin T assay you are using. And at our center, what we using the ROS, which did the HS troponin T in our center, but earlier we are using the conventional assay. So most of the center in our city also using conventional assay, but now it's use of HS troponin T increasing.